Hi everyone, welcome to this video. In this video, we are going to start a very important topic, that is neurocognitive disorders. So this is the first disorder we are discussing, and let's understand what are the important topics which we are going to cover in this video. First of all, we'll discuss some important terminologies. For example, what is cognition, what is consciousness, and then we'll move on to the important neurocognitive disorders. Very importantly, we'll discuss delirium. In fact, any branch you pick up or anywhere you practice in a medical profession, there may be a time when you deal with this condition, delirium. We'll also talk about dementia, what are the various types of dementias, and of course, we'll also talk about management. And third, we'll talk about amnestic disorder, another important neurocognitive disorder. And lastly, we'll end the video with some important frontal lobe syndromes. So let's begin. Now, when we talk about neurocognitive disorder, this is a new term which has been given both in DSM-5 and ICD-11. So basically, this word or this term neurocognitive disorder is a new term which has been proposed in these classification. Earlier, these conditions were known as organic mental disorders. In fact, in the basic, we have talked about this organic disorders, where we have talked about that there is a demonstrable cause or there is an apparent cause. So we'll talk about these organic mental disorders. Now let's understand. So this term, in fact, neurocognitive disorder, is a very apt term for these conditions. Now this term neuro is suggesting that these patients have a demonstrable brain dysfunction. So there is a brain dysfunction which is demonstrable, and remember, this brain dysfunction, it is acquired and it is not developmental. And this helps us differentiate it from certain other conditions. For example, mental retardation, which is also now known as intellectual disability, which is a developmental condition. So here we are saying that the brain dysfunction is acquired and it is not developmental. So this brain dysfunction, it leads to cognitive deficit. Again, if you recollect from the basic discussions we have talked about in MSc cognition, cognitive function. So here in this condition, in neurocognitive disorder, there is a brain dysfunction which leads to cognitive deficit. So it's a very apt name, neurocognitive disorders. Now let's talk about some important terminologies. First, we'll talk about cognition. We have also earlier discussed when we're talking about cognitive function in MSc. Cognition basically encompasses mental processes that helps us in acquiring information, help us to know things, to become aware of things. Now, cognition includes various domains, for example, memory, language, orientation, perception, executive function. So these are cognitive functions. So these are important domains included in cognition. And very aptly, when cognition is impaired, we call them as cognitive disorders. So we'll discuss that in these neurocognitive disorders, cognition is affected. Now, next terminology which we'll discuss is consciousness. Now, what is consciousness? Consciousness means awareness of self and the environment. So right now, when you're watching this video, you're aware of yourself and your environment. You're aware of time, place, person. So all of us are conscious right now. So this is consciousness, awareness. Now also there are various levels of consciousness. Let's discuss these levels. First is alertness. Alertness means when the person is awake, aware of the stimuli and also can respond to that stimuli. For example, right now you're watching this video and suppose you are getting nature's call. So what you'll do, you'll pause the video and you'll attend the nature's call. So all of you are alert. So this is alertness. Now second level of consciousness is lethargy or somnolence. Here the person is not fully active and may drift into sleep if the person is not stimulated. You know, sometimes during your lectures, you may be in this lethargy or somnolence state. Then third is obtundation. Obtundation is difficult to arouse. So the person is, again very difficult to arouse that person, and when aroused, the person may appear confused. So this is obtundation. Next level of consciousness is stupor. Now what is stupor? Stupor means there is no spontaneous response. So there is akinetic mutism. The person is not showing any movements, also not speaking much. So there is akinetic mutism. And often we see that they may respond only to very vigorous stimulation, and after vigorous stimulation they may do groaning. So that is a stupor. Stupor, you can say, is a state of semi-coma. And lastly is coma. Here the person is unconscious. They have no response to stimulation and their eyes are closed. So again, you can see the levels of consciousness and how the degree of consciousness is decreasing with these levels. So these are some important levels. Now let's understand, when do we say that there is impaired consciousness or the consciousness is not intact? Now usually they may use certain terms in the question which will suggest that the consciousness is impaired. For example, they may use this term that there is clouding of consciousness. What does this mean? This means that in the clear sky of consciousness, now there are clouds. So the consciousness is not clear anymore. Or they may use this term confusion. Again, this is suggesting that consciousness is impaired. Altered sensorium, that the sensorium is now altered. And sometimes they may tell that the person is disoriented. So these terms are suggesting that there is impairment of consciousness. Now also there are certain terms associated with consciousness. Let's discuss those terms as well. First we'll talk about twilight state. Now what is twilight state here? There is interruption of continuity of consciousness. So in between the person becomes normal and then this normal consciousness period is interrupted and may have an abrupt onset and it may abruptly end also. And unexpected violent acts or emotional outbursts may appear. So in between the person becomes normal and during period of abnormality there may be such acts of violence or emotional outburst. And such twilight state may occur in conditions like epilepsy or if there is any brain trauma. The next is dreamlike or oneroid state. Again, in dreamlike oneroid state there is impairment of consciousness. The person appears disoriented, confused, and hallucinations may also occur, especially visual hallucinations. In fact, we'll talk about this, that in neurocognitive disorder or organic mental disorders, visual hallucinations usually are more common. So this is dreamlike or oneroid state. And next is torpor. Again, torpor suggests that there is impairment of consciousness. So these were some important terminologies which we have talked about. Now let's talk about important neurocognitive disorders. So three important neurocognitive disorders which we are going to discuss. First, we'll talk about delirium. We'll discuss dementia and amnestic disorders. So let's start with delirium. In fact, remember, delirium is the most common organic mental disorder or the most common neurocognitive disorder. In fact, during your practice, any branch you choose, wherever you practice, you may come across patients with delirium. So delirium, when we talk about, we see that delirium has an acute onset. So first of all, what is onset? Onset means the time it takes from normal to abnormal state. So usually we see that patients who develop delirium, they develop it suddenly. So there is sudden onset. So clinically, when you will see patients or in the MCQs, you will see that the patient has developed symptoms within hours or within few days. So it has an acute onset. And when we see the course means progression. So we see that there is fluctuating course. So what is fluctuating course? That the symptoms are not stable. They keep on changing. So for example, you will see a patient, let us say, is admitted in the ICU with delirium. You will see that the symptoms may be more in the morning, then they may decrease in the afternoon, then again they may increase in the evening. So they have a fluctuating course. Now before coming to how to make a diagnosis of delirium, let's also understand some important risk factors. Now usually we see many times clinically and also in MCQs that certain risk factors may be present. These risk factors increase the likelihood of delirium. First is elderly age. So delirium, when we see, often we see that it is present in elderly. So in age 65 years or more. Of course, it can occur even in younger age. But elderly age is a risk factor. In fact, we'll also discuss this separately. Dementia, which is another neurocognitive disorder, it also is a risk factor. So patient with dementia again has a risk. They may also develop delirium. Now second risk factor is medical illness. Often we see that medical illness may increase the risk of delirium, and infections again can increase the risk of delirium, for example, pneumonia. In fact, during the COVID pandemic, we saw many patients with COVID developing delirium. So again, medical illnesses, again, severe anemia, burns, again they can increase the risk of delirium. Then third, very important is surgical illnesses. So surgical illnesses, surgical procedures, for example, somebody undergoing coronary artery bypass grafting, bypass surgeries, or person having fracture femur or undergoing hip replacement, or for example other surgical conditions like esophageal rupture, these may also have increased risk of delirium. Again, other condition like patient has undergone emergency appendectomy. So such clinical scenario may be given in the question. So surgical illnesses again can increase the risk of delirium. Also, sometimes we see that in RTA, that is road traffic accident, the patient after RTA may develop delirium. So surgical illnesses again may be given in the question. Also, very importantly, post-operative period. Often we see that patients may develop delirium after undergoing certain surgical procedures. So 1 day, 2 day, 3 days after the surgical procedure, you may find that patient has developed delirium. So again, this is very important, and often this may be given in the MCQs. Certain other risk factors include substance. Again, many substance withdrawal or intoxication can lead to delirium, and one very important substance whose withdrawal can lead to delirium. What is that substance? Very important. We'll talk about this: alcohol. So we'll talk about alcohol withdrawal. In alcohol withdrawal, patient may develop delirium, and that is known as delirium tremens. So substances may also be associated with delirium. Then next is polypharmacy. Again, often we see that patients may be taking multiple drugs for various conditions. For example, for hypertension, for any infection, for diabetes, and polypharmacy again may increase the risk of delirium. In fact, very importantly, drugs having anticholinergic property. So anticholinergic drugs may increase the risk of delirium. Also, in sensory deprivation, when there is sensory deprivation, that may increase the risk of delirium. For example, patients undergoing cataract surgery are given black patch, and because of that the person may develop delirium, and that is known as black patch delirium. So often we see that these risk factors may be given in the question, and they increase the likelihood of delirium. And out of these, very important for your exams especially is a surgical illness, post-operative period. Many times these are given in the question, but of course we will make the diagnosis of delirium based on the symptoms. Now let's understand how to make diagnosis of delirium. Now again, I'll tell you a mnemonic. Again, this mnemonic will help us remember the symptoms of delirium. Check consciousness at MSC. Now this mnemonic itself is telling you very important symptom in delirium. Check consciousness at MSC. So one very important symptom which we'll discuss, that is consciousness. So first let's talk about consciousness. In delirium, there is impairment of consciousness, and we have discussed this. When consciousness is impaired, some of the terms which may be mentioned in the question like clouding of consciousness, or there is confusion, altered sensorium, or there is reduced orientation. The awareness of self surrounding is reduced. Again, these terms mentioned in the question will give us clues that there is impairment of consciousness. Very important symptom which we'll discuss is seen in delirium. Next is remember at for attention. So there is attention is also impaired. So what is attention? We discussed when we're talking about MSc, attention means ability to focus at a particular stimulus. So in patients with delirium, their attention is impaired. So there is reduced ability to focus attention, or to sustain their attention, or to shift their attention from different stimuli. So often when we are talking to a patient in delirium, we may have to repeat a question multiple times because the attention of the patient is impaired. So there is impairment of consciousness, impairment of attention. And next, C for check, C for cognitive impairment. Again, since delirium is a neurocognitive disorder, so remember even cognition is also impaired. So there is cognitive impairment. So we have discussed various cognitive domains like memory. So memory is impaired, like recent immediate memory is impaired. And often we see that the remote memory may be intact. Then there are language impairment. When you're talking to the patient, there may be a lot of language impairments which we can notice. There is disorientation to time, place, person. So the person, it is morning time, patient may say that it is night time. So person may have disorientation to time or to place. Person is admitted in the hospital, but the patient says, I am at my home, or he is not identifying the family members, people around. So there is disorientation. Then perceptual abnormalities may be seen like illusion, hallucination. And which hallucination may be more common here? We have discussed this, that visual hallucinations are more common in organic mental disorders. So you may find that patient is admitted with delirium and he's seeing snakes on his bed, or he's seeing people around when no one is around. So their visual hallucinations may be present. So these are important symptoms. There is consciousness, attention is impaired, cognition is impaired. So these are important symptoms required to make the diagnosis. But often we see that some patients may have other additional features. So let's discuss some of those other features. So let's remember them as well. So M for motor disturbances. So often we see that patients in delirium may have motor abnormalities. These motor disturbances may be reduced. So sometimes we see that patient is just lying down on the bed, not speaking much, not moving much. So there are decrease in the motor activity. And some patients may even have higher than normal activity. So they're moving around, removing cannula, removing catheter. So the motor activities disturbances may be increased. In fact, there are various types of delirium. One is hyperactive delirium, in which the psychomotor activity, is increased. Psyche means mind, motor means the body. So psychomotor activity is increased. Then patients may have a hypoactive delirium, in which the psychomotor activity is reduced. And some patients may in fact also have mixed. Mixed means that there may be some time there may be increase in activity and other time there may be decrease in the activity. So they may have mixed type of activity. So these are some subtypes based on the psychomotor activity. And often we see sometimes, for example, in drug intoxication, in drug withdrawal, patient may have a hyperactive delirium. Hypoactive delirium may be seen in conditions like hepatic encephalopathy, renal encephalopathy, and then mixed may also be seen in various conditions. Then, so this was M. Then what is S? Remember S for sleep disturbances. So again, we may see that there may be sleep problems in patients with delirium. They may have decreased sleep. So family members or the hospital staff may tell you that the patient is sleeping very less. And sometimes there may be reversal of sleep-wake cycle. For example, the patient is awake in the night time and sleeping in the daytime. So there is reversal of sleep-wake cycle. Then E stands for emotional and other disturbances. So patient with delirium may also have emotional disturbances like depression, irritability, anxiety, and may also have other disturbances like delusions. Again, common delusion which may be seen in these patients is paranoid delusions. So patient may have paranoid delusions. For example, patient is suspecting that someone is mixing food in my, poison in my food, or patient may suspect that hospital staff wants to kill me. So such paranoid delusions may be seen in patients with delirium. So these are some important symptoms how we make a diagnosis of delirium. Again, remember, important is consciousness, attention is impaired, cognition is impaired, and these are certain additional symptoms which may also be present. Again, very important, especially for your MCQs, whenever you are making a diagnosis of delirium, try to see whether they have mentioned impairment of consciousness or not. This is very important when we are making diagnosis of delirium. Now also let's discuss some other features related with delirium. First is sundowning. Now sundowning phenomena may be seen with delirium. Now what is sundowning? Sundowning means that there is worsening of symptoms in the evening or night time. So again, you may observe, or family members may tell you, hospital staff may tell you that the symptoms were less severe in the morning time, but the symptoms became more and more, or there was worsening of symptoms by the evening or night time. So as the sun goes down, the symptoms increase. So this is sundowning. Then next is occupational delirium. What is occupational delirium? So in delirium, often we see that patient may behave as if he is still on his job. For example, a person is a carpenter and he's in delirium, he's admitted in the hospital, the person may do actions like as if he is putting a nail with the hammer, although there is no nail, there is no hammer, but he may behave as if he's still at his workplace. So this is occupational delirium. Next is flocculation, also known as carphologia. Many times we see that patients is in delirium, they have this aimless picking movements on the bed sheet, on their clothes. So they may do this movement as if they're picking something from their clothes or from the bed sheet, although there is nothing there. So this is flocculation or carphologia. Now when we talk about the neurotransmitters involved, one of the important neurotransmitter which is involved is acetylcholine, and in fact we see that there is decrease in acetylcholine. So that is why in fact we are discussing that anticholinergic drug, they may increase the risk of delirium. And when we talk about neuroanatomical area, reticular formation, which regulates attention, arousal, it is implicated in development of delirium. Now let's talk about some of the important etiologies of delirium. Again, there may be various conditions which may cause delirium, and sometimes we see that more than one factor may be present in a patient causing delirium. And in fact, if you've seen this movie, Ranveer Singh playing the character of Bajirao, in the end, they've shown that he developed some medical illness, probably some infection, and also has a lot of injury marks. And in the end, they've shown that he appears confused. There is impairment of consciousness. He sees horses coming in front of him with soldiers and they are attacking him, and he also starts fighting with them, although there is no one around. So visual hallucinations have also developed, and ultimately in the end he dies because of that. So they've shown delirium most likely in the movie. So let's discuss some important etiologies of delirium, and we will remember them with the acronym of delirium itself. So first is D for drugs. So various drugs may cause delirium, such as alcohol, as we have discussed. Sedatives can cause. Anticholinergic drugs, we have discussed, can increase the risk of delirium. Anticonvulsant drugs, even other drugs like antihypertensive drug, antineoplastic drugs, antibiotics, and many other drugs, they can cause delirium. Then next is E for endocrinal. So again, endocrinal causes such as hypo or hyperthyroidism, hyperpituitism, and many other endocrinal abnormalities can cause delirium. Then L stands for liver. Hepatic encephalopathy again can also cause a delirium. I is infections, again systemic infections such as septicemia, pneumonia, COVID. So infections can also cause a delirium. R is renal such as uremic encephalopathy. Again, renal causes may also cause delirium. I is intracranial, that is CNS causes. So CNS causes can also cause delirium such as epilepsy, tumor, there is injury, there is CNS infection. So those are also can cause delirium. Now, in this mnemonic, let's change U to O. Again, many times we see in medical college in the lecture hall, you will see on the benches, things like this are engraved. You know, U and I become R. So from there we can remember. So here what we have done, so U and I, so what we have done, we have changed U to O. So O stands for other. So other causes such as heat, sleep deprivation, they can also cause delirium. And lastly, M stands for metabolic causes such as hypoxia, hypoglycemia, electrolyte imbalance. So these are some of the important etiologies of delirium. Now also there is something known as end of life delirium. It is also known as terminal restlessness or terminal delirium. So often it is seen with patients having some terminal illness such as advanced cancer. Here, delirium develops most often in the last 24 to 48 hours of life. So just before death, in the last 24 to 48 hours, the person may develop delirium. Sometimes it can also develop even weeks before the death. And usually we see that multiple factors may play a role in development of delirium, such as multi-organ failure is there or dehydration. So there may be multiple factors, and in some patients it may be reversible, while in some patients we give palliative care. So this is end of life delirium. Now let's discuss some important differential diagnosis, how to differentiate delirium with some of the other psychiatric conditions. So let's first discuss how to differentiate delirium from psychotic conditions like schizophrenia. Now one very important point which we have been discussing is that consciousness, we know, in delirium is impaired, while in other psychiatric disorders, including schizophrenia, consciousness is intact. So this is one very important difference. So consciousness helps us differentiate delirium from some of the other psychiatric conditions. Also, when we'll discuss schizophrenia and other psychotic disorders, we'll talk about one more psychotic disorder, which is acute psychosis. Now, in acute psychosis, also the symptoms, they develop suddenly. So there is a sudden onset, which is again similar to delirium we have just discussed. Also, even in acute psychosis, we will learn that fever may be present at the onset. So sometimes delirium and acute psychosis are close differential diagnoses of each other. Both of them may have delusions, hallucination. So what is the important point of difference? The point of difference is consciousness is impaired in delirium while it is intact in acute psychosis. Also, when we talk about symptoms like delusions, hallucination, they are usually transient, may occur for less duration and usually are less organized, less elaborative. While in psychotic disorders like schizophrenia, they are more constant, may be present for a longer time, and they are better organized. They are more elaborative. Patient may give more information or more elaboration of those phenomena. Also, we know that one of the hallucination which is more common in delirium is visual hallucination. Of course, visual hallucination can also occur in schizophrenia and other psychotic disorders, but visual hallucination usually is the most common hallucination in delirium. Now, let's discuss how to differentiate delirium from dementia. So, dementia is also a neurocognitive disorder, which we'll discuss. So, first of all, when we talk about the onset, so we have already discussed onset of delirium. It is sudden in onset, short duration of onset is there, while dementia usually is gradual and insidious. So it may take months or years for dementia to develop. There is one exception which we'll discuss, vascular dementia. Here, due to stroke, the onset may be sudden. Then when we talk about a very important point of difference, that is consciousness. Again, very important to remember, in delirium, consciousness is impaired, while in dementia, consciousness is intact. Now, coming to the symptoms, so we have discussed symptoms of delirium. We'll also discuss symptoms of dementia. So, in both, we know that there is cognitive impairment, and in delirium, along with cognitive impairment, there is also consciousness, attention that is impaired. And when we talk about the symptom progression, usually in delirium, we see that the symptoms, they fluctuate, while in dementia, they are stable over time and usually they progress with time. So these are some important points of difference between delirium and dementia. Also, there is something known as beclouded dementia. What is beclouded dementia? Here, occasionally delirium may occur in a patient who has pre-existing dementia. So we have discussed this already, that dementia sometimes is also a risk factor for delirium. And sometimes patients having a pre-existing dementia, on the top of it, may also develop delirium. That is known as beclouded dementia. Now let's talk about the assessment of delirium. Now when we are doing assessment in delirium, we do all the basic investigations to find the underlying condition, the underlying cause which is causing delirium. So for example, we'll do investigation like CBC, electrolytes, liver function test, kidney function test. And again, depending on the underlying cause, we may also do certain other investigations. For example, we may do a brain scan if we are suspecting any intracranial cause like an injury or a tumor. So we'll do all those assessments to find out the cause. Also, there are certain investigations, assessments which we do for delirium. One of the important diagnostic tool which we use is CAM, that is confusion assessment method. Again, always see the names here. The name is telling you confusion assessment method. It is used for which condition? So this name is telling confusion, we know, is seen in delirium. So this is used for delirium. So it's a diagnostic tool to identify delirium, and it basically focuses on 4 areas. So we see acute onset and fluctuating course, which we know is a characteristic of delirium. We see inattention, there is disorganized thinking and altered level of consciousness. So these are the 4 areas which are focused on in this confusion assessment method. Also, there is another investigation which can be used, that is EEG. What is EEG? It is electroencephalogram. Now, what is ECG? ECG is electrocardiogram. It measures the electrical activity of the heart. So what does EEG measure? It measures the electrical activity of the brain. Again, this is not a usual investigation which we do in delirium, but if we do EEG in patients with delirium, whatever may be the cause, so we see diffuse slowing of the background activity. We'll talk about EEG in detail when we'll talk about sleep physiology. So look at this EEG in delirium. So when we see these waves, there is diffuse slowing of the waves in delirium. So again, this is important. Now, but there is one important exception to this. When we see patients developing delirium due to alcohol or sedative hypnotic withdrawal, such as benzodiazepine withdrawal, there is low voltage fast activity. So remember, in alcohol or sedative hypnotic withdrawal in the EEG, there is low voltage fast activity. Also, MMSE, when we do, MMSE is mini mental state examination, which we'll discuss in detail when we talk about dementia. So MMSE can also be used for delirium because MMSE usually it is for assessing the cognitive functions. So MMSE can also be used in delirium because we know in delirium cognitive functions are also impaired. Now let's talk about the treatment of delirium. Now in the treatment of delirium, first and very important point we need to remember is prevention. So prevention is a very important part of treatment because we know that there are certain risk factors which can increase the risk of delirium. So it's important to identify those risk factors and that can help us to prevent delirium. Now if delirium has developed, first and very important part of the treatment is treat the underlying cause. So it's important to identify the cause of delirium because we know that most of the cases of delirium, they are reversible. So if we are able to find out the cause and we are able to treat that, delirium will be reversed. It's important to remember delirium, it's a life threatening condition, it's a medical emergency, but we know it is reversible. So it's very important to identify the cause. And usually the course of delirium in most of the cases is 7 days. While it of course it may be variable, but in most of the patients we see that the course of delirium is around 7 days. Now in the treatment, physical support again is very important. We should prevent patient from getting into accidents. So there should be not much furniture or objects around the patient because the patient is having impaired consciousness. They may collide and they may hurt themselves. So it's very important to provide physical support. Also, regular orientation is important to time, place, person. For example, we can keep the patient bed near the window. So window view will help the patient to remain oriented. When is the daytime, when is the night time. We can put a calendar, a big calendar in the room, a big wall clock in the room so that he is regularly oriented. So it's important to give a regular orientation to time, place and person to the patient. Now let's talk about pharmacotherapy. So drugs can also be used in managing delirium. So primary treatment is that we have to treat the cause, but we can manage the symptoms of the patient with some of the drugs. So antipsychotics may be used in the management of delirium for managing symptoms such as delusions, hallucinations, agitation. In fact, some of the drugs which are used are haloperidol. Haloperidol, we'll discuss, it's a first generation antipsychotic. In fact, it is one of the most common drug which is used in delirium. Why it is most commonly used? Because this drug has less of anticholinergic property. So less anticholinergic action, less hypotensive action is there. So it is one of the commonly used drug used in delirium. Then even second generation antipsychotics such as olanzapine, even risperidone and even drugs like quetiapine, they can also be used. Of course, we know haloperidol has high EPS potential, so one has to be very careful when we are using such drugs. So remember, most commonly haloperidol is used and other antipsychotics may also be used. Now also, let's discuss the role of benzodiazepine. Now earlier benzodiazepines were also used for managing symptoms like agitation. Sometimes low dose of benzodiazepines may also be used to manage insomnia. But again, it's important to remember that these drugs should be used carefully because sometimes they may even worsen delirium. They can cause confusion and they may worsen delirium. So benzodiazepine has an important role in one specific delirium. What is that delirium? So it is preferred for treatment of alcohol withdrawal delirium, that is known as delirium tremens. For delirium tremens, we'll discuss when we talk about alcohol that benzodiazepines are the drug of choice. So for delirium tremens, the preferred drug will be benzodiazepines. Also, ECT, that is electroconvulsive therapy. So electro means we pass electric current in the scalp and which produces convulsions. So ECT may be used, and in fact it may be the last resort. That means if the patient is not responding to drugs, then we may also consider ECT in patients having delirium with severe agitation. But again, one has to be very careful. We should monitor because sometimes ECT can also develop delirium. So this was about the management of delirium. Now we'll discuss another important neurocognitive disorder, which is dementia. Now dementia, usually we define that it is progressive cognitive impairment. So it's a neurocognitive disorder. So there is cognitive impairment, which is usually progressive. And very important to remember, in clear consciousness. So why we are saying in clear consciousness? Because if consciousness is also affected, then diagnosis would change to delirium. So it's very important to remember this transition. When we talked about delirium, we discussed that both consciousness and cognition are affected, while in dementia, only there is cognitive impairment, consciousness is intact. In DSM-5, they have combined dementia and amnestic disorder into one new entity, which is known as major neurocognitive disorders. So there is something also known as mild neurocognitive disorder. There the symptoms are mild. So remember, dementia in DSM-5 is now included in the term major neurocognitive disorders. Now let's talk about the epidemiology. Now usually when we talk about prevalence, the prevalence of dementia, it increases with age. In general population, if we see a population of 65 years or above people, the prevalence of dementia is around 5%. And when we see the population of more than 85 years of age, then this prevalence increases to 20 to 40%. Now let's understand how do we make a diagnosis of dementia, or what are the symptoms of dementia. So again, as we discussed, there is cognitive impairment. Now often when I ask this question to the students that what are the symptoms of dementia, usually I get a very common answer. So there is memory impairment. Please understand, we are saying that there is cognitive impairment. Memory is a part of cognition. Yes, it may be affected usually, but it is not necessary. So let me give you a mnemonic. So since students are saying, sir, there is memory impairment, so I made a mnemonic. The mnemonic to remember various cognitive domains which are affected in dementia, the mnemonic is memory lapse. So there are 6 important cognitive domains which we'll discuss, which may be impaired. First is memory. So memory may be impaired, and let's also correlate some neurological terms. So impairment of memory we know is known as amnesia. Now usually in amnesia, the person may have inability to learn new information or to recollect past information. So in dementia, usually we see that initially it is the recent memory which gets affected first. So often we get complaints such as forgetting dates. We may have to repeat the question. Patient may repeat questions again and again. Or the person misplaces objects, does not remember where he has kept important items. And gradually even immediate memory and remote memory may get lost in the last. So patient may have also impairment of recollecting past events. Now in severe forms, when we see various other aspects of the memory, they may also get affected. For example, semantic memory, memory of facts, or autobiographical memory, memory of personal events or people, those also may get affected. And implicit memory, what is implicit memory? That is procedural memory, unconscious learning of skills. For example, if you remember the first time when you started driving, you were very cautious, looking all the mirrors. But once you learn, even without noticing, you are driving, you're listening to music, you are thinking something, and still you are driving. So that is implicit or procedural memory. So that may also get affected in the severe cases. Now in the mnemonic, next is L. L is language. So there is also language impairment. Again, if we correlate this with neurology, what is the disturbance of language known as aphasia? So patient may have impairment in language and patient may present. In mild cases, the patient may have word finding difficulty, getting the right word for a particular object, may mispronounce a word. So there may be word finding difficulty. And in severe impairment, the patient may not be even able to recall names of close friends, family, and eventually the speech may become incomprehensible. You may not be able to understand what he's speaking. So language impairment may occur. Now next, cognitive impairment. So in the mnemonic memory lapse, A is attention. What is attention? Attention means ability to focus on a particular stimuli. So here, the complex attention of the person is impaired. So what is complex attention? Complex attention means focusing on multiple stimuli or competing stimuli. So in patients having impairment in complex attention, initially normal tasks may take longer time and gradually there may be increased difficulty in environments where there may be multiple stimuli. For example, right now you're watching this video, so you're seeing me on the screen, you're listening to what I'm speaking and you may be making your notes. So you're focusing on multiple stimuli. So a person having problems in complex attention may not be able to attend the lecture. Similarly, patient may have difficulty in watching television, listening to radio when there are competing stimuli, or when person is having multiple conversations, they may have difficulty. Now next, cognitive impairment. So memory lapse. P is perceptual motor impairment. So there is problem in perceptual motor coordination. So here the person may present with apraxia. Now praxia means movement. So what is apraxia? Inability to perform learned motor functions despite there is an intact motor function. So motor functions are intact, still the person is having difficulty in performing learned motor functions. So in early stages, the person may present with difficulty in handling tools, or the patient may have difficulty in handling machines, or maybe having difficulty in various tasks, for example, knitting. And later on, the patient may not be able to do tasks such as bathing or buttoning, unbuttoning the clothes, tying, untying the shoelaces, eating. Even those tasks may become difficult. So this is apraxia. Patient may also have agnosia. What is agnosia? It is inability to recognize object despite there is intact sensory function. So if I show this object to the patient, patient may not be able to identify this as a pen. So they have difficulty in recognizing object. So what is prosopagnosia? It is inability to recognize faces. So patient may not be able to recognize even faces of family members, friend. And in later on stages, sometimes the patient may not be able to even recognize his own reflection in the mirror. So there are perceptual motor impairment. Now next, in the cognitive impairment, in the mnemonic memory lapse, S is social cognition. Now, what is social cognition? Social cognition means recognition of emotions of others, of family members. So family members sometimes complain that nowadays, even if we cry in front of the patient does not come and console us. While earlier he used to come and ask if ever we appear upset, as if he's turned very cold. Now this is occurring because there is problem in social cognition. Sometimes this may be manifested as disinhibitory behavior. Patient may make inappropriate sexual or political comments. So there is impairment of social cognition. And last is E. E is executive functioning. So what is executive functioning? Executive functioning means planning, decision making. So these patients may have problems in executive function. So, often every time after final exams, you make a plan that we'll go to Goa, but that plan never gets finalized. But now you say, no, after my exam, I'll go to Goa. So when we have to go to Goa, you have to make a lot of planning, which hotels to book, which flights to book, where to go, and you have to make those decisions. So a lot of executive functioning is required in such task. These patients having problems in executive functioning will not be able to perform such task. So many times we get such complaints that they have difficulty in preparing meals, managing their medicines, managing their finances. This is because there is problem in executive functioning, and later on even the day-to-day activities may become very difficult. So these are the important cognitive impairments which may be seen in patients with dementia. When we call dementia, when these cognitive impairments, they result in a significant impairment of functioning, that is, there is a decline from the previous level of functioning, then we say that patient has dementia. Now let's talk about some additional symptoms. First, we'll talk about neuropsychiatric manifestations. These are behavioral and psychological symptoms which may also be present. In fact, they are commonly present in patients with dementia. They are not required in making the diagnosis, but we should know that these may occur because these need to be addressed, and if they are present, they may require treatment. Also, we see a lot of time these neuropsychiatric manifestations, they may also increase the caregiver distress. So let's discuss some of the important neuropsychiatric manifestation. First is mood changes. Now, mood changes can also be seen in patients with dementia. For example, depressive symptoms. In fact, depressive symptoms are the most common neuropsychiatric symptoms in dementia. Again, it's an important point which you should remember. So many times when patients with dementia also have depressive symptoms, we also treat those depressive symptoms. Sometimes, although rarely, even mania may also occur in patients with dementia. Second is anxiety symptoms. Even anxiety symptoms can occur in patients with dementia. These are also common. And in fact, there is one very important reaction, that is a catastrophic reaction. As the name suggests, catastrophic, something very severe. So it's a severe reaction. It's a agitation which occurs secondary to the subjective awareness of intellectual deficit. Now, normally when we talk about patients in dementia, they are not aware or they don't have insight of their cognitive deficits. For example, if we tell a patient having dementia that you are having memory issues, you are not able to remember, the person may in fact even start arguing. He may defend himself saying, no, I am not having any problem. So usually patients with dementia may not have that subjective awareness. But sometimes it is seen that under stressful situation, they may have that insight or awareness that I am forgetting things, or the person may start having an insight that I am having symptoms like aphasia. So that may lead to a agitated reaction that is known as catastrophic reaction. So catastrophic reaction can occur in patients with dementia. Also, these patients may also have sleep disturbances. There may be disrupted, fragmented sleep may also occur in patients with dementia. Again, very important that personality changes. Also, patients with dementia may have personality changes. Sometimes patient may become apathetic, they may have amotivation. So they may become introverted and may become less concerned about others. On the other hand, sometimes patients may also have disinhibited behavior. There may be impulsivity. These patients may make inappropriate comments. They may make inappropriate jokes. So there are also personality changes which may occur in patients with dementia. Also very important, even psychotic symptoms such as delusions, hallucinations may also occur in patients with dementia. Most common delusion in patients with dementia is a delusion of persecution, and as we have discussed, hallucination, which is the most common hallucination, it's a organic mental disorder, and we know visual hallucinations are the most common hallucinations which may occur in patients with dementia. Of course, other delusions, other hallucinations may also occur, and usually these hallucinations may develop in the later stages of the illness. Also, these patients may show agitation, aggression may be there in the patients, and it may be both physical or it may be verbal, and sometimes these may lead to hospitalization of the patient as well. So these were some important neuropsychiatric manifestations which can occur in dementia. Also, patients with dementia may also have neurological symptoms. For example, patient may have seizures, there may be myoclonic jerks, and patient may also show focal neurological signs that usually would correspond to the site of the injury. For example, in vascular dementia, patient may have extensor plantar response, there may be gait abnormalities depending on which area of the brain is affected. So these are some important other symptoms which may also be seen in patients with dementia, and many times these especially neuropsychiatric manifestations, they are also added as a specifier when we are making the diagnosis of dementia. Now let's take on some controversy. Why Katappa killed Bahubali, this became a national controversy, but we know why he killed, and it was clear in part 2. but there are some controversies which remain controversy. So let's take up those controversy. Now first is the most common type of dementia. Now overall, if you're asked which is the most common type of dementia, again there is little controversy about it. We know Alzheimer's disease is the most common type of dementia and usually seen in 70 to 80% of the cases. Again, it may be seen alone or in combination with the other etiologies. Now the question comes, which is the second most common overall cause of dementia? Now please remember, now the answer has changed. It is Lewy body dementia. So Lewy body dementia or Lewy body disease is seen in 15 to 35% of the cases. So now this is the second most common overall cause of dementia, followed by vascular dementia seen in around 5 to 20%. This is according to Kaplan and Sadok latest edition, that is the 11th edition, as well as ICD-11, which is the latest version of ICD, that also mentions that Lewy body dementia now is the second most common cause of overall dementia, especially in elderly. Now let's understand what is early onset dementia. Now we know that dementia usually is a disease of late age. So let us say this is early age and this is late age. So dementia, we say, is a disease of late age. But there are some patients who may develop dementia at an early age. So that small proportion of patients, we say they have early onset dementia. So what is early onset dementia? When the dementia occurs before the age of 65 years, then that is known as early onset dementia. Now let's discuss some of the important causes of early onset dementia. Now if you are asked the most common remains the same, that is Alzheimer's disease. Now again, slight controversy, which is the second most common cause of early onset dementia. Again, some book says that it is seen two important conditions may be the second most common. So remember, frontotemporal dementia, that is PIC disease, and next is vascular dementia. If you have to choose one, you may go for frontotemporal dementia as the second most common, but remember both these are closely seen at the second position. So these are some causes of early onset dementia. Now let's understand some classifications of dementia. So two types of classification we'll discuss. First of all, let's understand that dementia, as we have discussed, most of the cases they are progressive, they are irreversible. But there are some patients who may have reversible cause. In fact, 10 to 15% of the patients may have a reversible cause of dementia. That means if we are able to identify the cause and we are able to reverse that, so dementia may be reversed. So let's discuss some important reversible causes of dementia. First is the neurosurgical condition. So there may be certain neurosurgical conditions in which if the patient develops dementia and we are able to reverse the condition, dementia will be reversed. So conditions like subdural hematoma, normal pressure hydrocephalus, that is NPH, then intracranial tumors, intracranial abscesses. Again, if we are able to treat them, dementia will also be reversed. So these are some neurosurgical conditions. Then second is infections. Also there are certain infections, for example, encephalitis, neurosyphilis, Lyme disease. Again, if you are able to treat these diseases, dementia will also be reversed. Then third and very important are the metabolic causes. In metabolic causes, one very important vitamin deficiency which you should know is deficiency of vitamin B12. In fact, even other deficiencies, for example, folate, niacin, even thiamine, these can also cause reversible dementia. Then in the endocrinal cause, again very important, one important cause is hypothyroidism. So dementia due to hypothyroidism, if we treat it, dementia will also be reversed. Then even hyperthyroidism can also cause reversible dementia. Even hypo and hyperparathyroidism can also cause reversible dementia. So these are some important metabolic causes. And lastly, you can remember some other causes such as certain drugs, toxins, and very important, alcohol. Now it is seen that alcohol we'll talk about also causes certain other neurocognitive disorders, for example, Wernicke's, encephalopathy, Korsakoff syndrome. Alcohol can also cause dementia. And interestingly, dementia due to alcohol may be reversible. So what we have to tell the patient that stop alcohol. Within a year of stopping alcohol, all the brain changes in fact which have occurred may also be reversed. So alcohol can also cause reversible dementia. So these are some important reversible causes of dementia. Now there is one more important classification, and we can divide dementia based on the site of lesion. So this classification, we divide dementia into cortical dementia and subcortical dementia. Now let's try to understand what is this. Suppose this is the cortex and this is the subcortex. When we say cortical dementia, that means the initial site of lesion is the cortex. But maybe over the course of time, even the subcortex get affected. Similarly, in subcortical dementia, which area is getting affected first? It's the subcortex. But over the course of time, maybe the entire brain may get affected. So we're talking about the initial area of the insult or lesion. So cortical dementia and subcortical dementia is basically divided on the site of lesion. In cortical dementia, there is early involvement of cortical structures. Hence, there is early appearance of cognitive dysfunctions such as amnesia, apraxia, agnosia, aphasia, even acalculia. That is, there are problems in arithmetics or calculations. So, the cortical dementia initially would have more of these cortical dysfunction. While when we talk about subcortical dementia, there is early involvement of subcortical structures such as the basal ganglia, brainstem nuclei, cerebellum. And as you can see, a lot of structures which are associated with movements, they are getting affected first in subcortical dementia. That is why in subcortical dementia, the early presentation of motor symptoms may occur. For example, tics, chorea, abnormal movements. Such movements can occur more in the initial presentation in subcortical dementia. So also, there is significant disturbances of executive functioning. There may also be prominent neuropsychiatric manifestation, that is behavioral and psychological symptoms may occur more in subcortical dementia initially. For example, apathy, depression, bradyphrenia, that is slowness of thinking. So these symptoms may occur more in the initial presentation. So one of the important points to differentiate cortical and subcortical dementia clinically is that in subcortical dementia, patient may have more of motor abnormalities in the initial manifestation. So again, this point clinically can sometimes help us differentiate between cortical and subcortical dementia. Now the question which usually is asked is some important examples of cortical and subcortical dementia. So please remember, Alzheimer's disease, which is the most common overall cause of dementia, is a cortical dementia. Even pig disease, I always say in psychiatry, remember the name we have discussed, pig disease is also known as frontotemporal dementia. The name is telling you frontal and temporal lobes are getting affected first. So it is a cortical dementia. Even one of the prion disease, Creutzfeldt-Jakob disease, CJD, also you see cortical structures getting involved initially. Then coming to the subcortical dementia, diseases like Parkinson's disease, Huntington's disease, multiple sclerosis, PSP, that is progressive supranuclear palsy, Wilson's disease. So a lot of these diseases which you will also read in medicine, they are also causes of subcortical dementia. In fact, when we'll read them in medicine, a lot of these diseases we know have motor abnormalities. For example, in Parkinson's disease, we know there is tremors, there is rigidity, there is bradykinesia. So a lot of motor abnormality, and as we have discussed that since it's subcortical dementia, motor manifestations may be seen initially in the early part of the disease. Now, also remember there may be some dementias which may have a mixed presentation. For example, vascular dementia. Now, vascular dementia, we'll discuss, it occurs because of vascular insult in the brain. So again, it can occur in both cortex or in the subcortical areas. So again, it may have a mixed presentation of both cortical and subcortical areas. Also, we'll talk about Lewy body dementia, Lewy body disease. We'll discuss that it has 3 core features, and there we'll correlate that it may also have manifestation of both the cortex and the subcortex. So these may have certain mixed presentations. Now let's talk about some important individual causes of dementia. First, we'll talk about Alzheimer's disease. Now, we already know Alzheimer's disease is the most common type of dementia. And when we talk about the onset, the symptoms usually develop gradually and they have an insidious onset. So, symptoms may take months or years to develop. So, family members may give you a history that symptoms were present for months or even years and gradually they have increased. Now, when we talk about the presentation, the most common presentation is memory deficits. So, amnesia is one of the common complaints in Alzheimer's dementia, and also language disturbance, aphasia may also be seen. And gradually we see that even other cognitive domains, they may also be seen. For example, patient may have agnosia, apraxia. So, these symptoms may also gradually develop over the course of time. And lack of insight into their deficits usually may be seen in patients with Alzheimer's dementia. So they may not be aware that they are having these cognitive impairments, and in later stages, as we have discussed, even the motor symptoms like tremors, rigidity, these may also come into picture. So they may occur in the later stages. Now, talking about the epidemiology, it is seen that Alzheimer's dementia is slightly more common in females than males. Now, let's talk about some important genetics of Alzheimer's disease. Now, Alzheimer's disease, when we talk about genetics, can be divided into two. One is early onset Alzheimer's disease and the another is late onset Alzheimer's disease. Let's discuss some important genes which are affected in these Alzheimer's disease. Now, talking about early onset Alzheimer's disease, mutation in 3 genetic loci has been identified. First is the APP gene. What is APP? APP is amyloid precursor protein, APP gene, that is on chromosome 21. So it has been seen that mutation in this APP gene has been associated with early onset Alzheimer's disease. And also you can remember chromosome 21. There is something associated with chromosome 21. We talk about trisomy 21. So what is trisomy 21? Down syndrome. In fact, it is seen that patients who have Down syndrome may also develop dementia at an early age, presenile dementia. And usually what is the cause of dementia in those individuals also? You can correlate because APP gene is on chromosome 21. So it is seen that there is an increased risk of Alzheimer's disease in Down syndrome. So this is again an important point which you should remember. So one of the genes for early onset Alzheimer's disease is APP gene. Then there are other genes as well, PS1 presenilin 1 and PS2 presenilin 2. These are also involved in early onset Alzheimer's disease. So remember, PS1 is not on chromosome 1, it is on chromosome 14. PS2 is on chromosome 1. So these are 3 important genetic loci which have been identified in early onset Alzheimer's disease. And if we talk about the proportion, most common early onset Alzheimer's disease, most common gene is PS1, nearly in 20% of the cases. 5% is the APP gene and 1%, remember, chromosome 1, PS2 is on chromosome 1 and it is 1%. So these were some important genetic loci of early onset Alzheimer's disease. Then there is late onset Alzheimer's disease. Now again, one important allele which has been identified, apolipoprotein E epsilon 4 allele, that is ApoE4. So this has been associated with late onset Alzheimer's disease, and in fact it is on chromosome 19. It is seen that a single copy of ApoE4, it increases the risk 2 to 4 times of late onset Alzheimer's disease, and 2 copy of ApoE4 increase the risk to 4 to 8 times. Then there are other genes also which have been identified, but this is one of the important genes you can remember for late onset Alzheimer's disease. Now let's try to understand some important pathophysiology of Alzheimer's disease. The one very important protein which we'll talk about is APP, that is amyloid precursor protein. Now this is in fact a transmembranous protein, and various secretase enzymes, they act upon it. And let's understand what are the important enzymes which act upon this APP, which leads to development of what is known as A-beta deposits. So we know that it has different sites for beta secretase, alpha secretase and gamma secretase. Now gamma secretase is a common enzyme in the 2 pathways which we'll discuss. So let's discuss what happens if beta secretase and alpha secretase, they act on this APP protein. So when beta secretase act, this is the product which occurs, and when alpha secretase act on this, this is the product which is formed. And as we discuss, on both gamma secretase then acts. So when there is cleavage by gamma secretase, so this beta secretase product, it leads to A beta 42, which is toxic, and A beta 40, which is non-toxic. So remember this pathway, when first beta secretase act, then gamma secretase act, it leads to A beta 42, A beta 40. These are the products. And when alpha secretase followed by gamma secretase act, it leads to P3, which is non-toxic. So this A beta, especially 42, which occurs because of act of first by beta secretase, then by gamma secretase. This is very important, as self-aggregation of these A beta into soluble low N oligomers, they cause synaptotoxicity, which occurs in Alzheimer's disease. And a soluble A beta, these deposits, they are strongly correlated with the cortical synapse loss. That is the early pathological event which occurs in Alzheimer's disease, that is synaptic loss, which subsequently leads to cognitive impairment. So it's very important to remember that even these soluble A beta deposits, they are also strongly correlated with synaptic loss. Now eventually what happens, these amyloids, there is polymerization, and that leads to fibril formation, and ultimately that leads to what is known as amyloid plaques. So when we talk about these amyloid plaques, there is a central core which is made up of insoluble fibrillar A beta deposits, and this is surrounded by dystrophic neurites, that means the dystrophic nerves, then also of microglial cells, reactive astrocytes. So that forms the surrounding of this core. So that is why these are known as neurotic plaques. So there is basically A beta deposits are there in the center, and that is surrounded by dystrophic neurites. Now it is seen that mutation in the APP gene, it increases metabolism of the APP by beta secretase. So we know two important secretase, beta and gamma. When they act, that leads to A beta deposit. So in APP gene mutation, you can remember there is increased metabolism of APP by beta secretase, and mutations in PS1, PS2, they are linked with gamma secretase activity. So here we can correlate genetics with pathophysiology of Alzheimer's disease. How these mutations, they are eventually affecting the APP breakdown. Also, when we talk about these A beta deposits, it's important to remember that they also accumulate in the cerebral arterioles, and that is what is known as CAA, that is cerebral amyloid angiopathy. So sometimes the cardiovascular events that can occur because of these CAA, and these A beta deposit, in fact, they are also contributing to the phosphorylation of tau protein. We'll talk about that, leading to neurofibrillary tangles. So there is also neurofibrillary tangles which also occur in Alzheimer's disease, and how A beta are also linked with these neurofibrillary tangles. Now let's talk about some important points in pathology. Coming to macroscopic findings, so when we see an MRI of a patient with Alzheimer's disease, or suppose the patient has died and we are looking at the brain after doing the postmortem. So when we see the brain with the naked eyes, what are the findings? So there is diffuse atrophy, so there is a shrinkage of the brain with flattened cortical sulci, and there is enlarged cerebral ventricle. So there is a diffuse atrophy of the brain which is seen, and typically the brain atrophy, it begins in the medial temporal lobes and it spreads to inferior temporal, lateral and medial parietal lobe, and also in the frontal lobe. In fact, it is seen that Alzheimer's disease, it has a parieto-temporal distribution. So initially it is more of parietal and the temporal lobes which are affected, and of course as we know that gradually the entire cortex and even other areas of the brain may also get involved, but initially it is more of parietal and temporal areas which are affected. Now seeing the MRI image, we can also see, so this is MRI of a normal brain and this is MRI image of patient with the Alzheimer's disease, and as we can see from the image that there is ventricular enlargement, we can see there is atrophy of the brain, especially the cortex. We can see also there is volume loss of hippocampus, and which we can appreciate by the prominent temporal horn of the lateral ventricle. So nearby there is hippocampus, so the prominent temporal horn of the lateral ventricle is also hinting towards the hippocampal atrophy. Now coming to the microscopic finding, one very important microscopic finding which we know is there is amyloid plaques. These are also known as senile or neurotic plaques, and these are found first throughout the neocortex and followed by the entorhinal cortex, hippocampus, and subsequently even the subcortical areas, they also get affected. Now if you see the image, as you can see in this image, the neurotic plaques, there is a central core is there, and surrounding it these dystrophic neurites and other reactionary cells are present. So this is how neurotic plaque appears in the pathological finding. Now, when we talk about the microscopic finding, another important finding is neurofibrillary tangles. Now, these neurofibrillary tangles, these are basically intracellular inclusion bodies which contain paired helical filaments of abnormally phosphorylated tau proteins. Let's understand what are these neurofibrillary tangles. Now, normally these are the tau proteins, they bind to and they stabilize the microtubules. So, in the cell, the microtubules, as you can see, these microtubules, they are stabilized by tau, and these microtubules, we know they are required for axonal transport in the neurons. So, what is this MAPT? MAPT is microtubule associated protein tau. Now, what is happening in Alzheimer's disease? There is hyperphosphorylation of these tau protein, as you can see in this image. So, there is hyperphosphorylation of these tau proteins which destabilizes the microtubules, and subsequently there is loss of synaptic function. And what happens, these hyperphosphorylated tau proteins, they form paired helical filaments and they aggregate into these flame-like cells, that is neurofibrillary tangles. So if we see the microscopic finding in Alzheimer's disease, these flame-shaped cells, these are neurofibrillary tangles, which are because of aggregated hyperphosphorylated tau proteins. So when we talk about these NFTs, they are again first found in the entorhinal cortex, in the medial temporal lobe, and they spread widely in the cortical structures, hippocampus. But it is important to remember that they are not just confined to Alzheimer's dementia. They can also occur even in frontotemporal dementia. So they are not pathognomic of Alzheimer's disease. Amyloid plaques and NFTs, they can be seen even in elderly with normal cognition. So it's not just in Alzheimer's dementia. In fact, even in elderly with normal cognition, they may also show these findings. Although when we talk about Alzheimer's disease, they are more widespread. They are seen in more areas of the brain. Also, when we talk about the neuropathological diagnosis of Alzheimer's disease, for making a neuropathological diagnosis, both amyloid plaques and neurofibrillary tangles should be present on the post-mortem examination. And very important point is, number of NFTs, neurofibrillary tangles, they correlate better with the degree of dementia. That means more the NFTs, higher the severity than the number of amyloid plaques. So this is again an important finding which you can remember. In the microscopic findings, other findings include granulovacular degeneration and even Hirano bodies. These are needle-shaped bodies which can also occur. And most commonly, these are affecting the pyramidal neurons in the hippocampus, and these may be found. Now, coming to the neurotransmitter, let's understand some important changes in the neurotransmitter which occurs in Alzheimer's disease. First and very important, there is a decrease in acetylcholine. So there is in fact loss of cholinergic neurons in nucleus basalis of Meynert and other areas. So decrease in acetylcholine is very important change which occurs in the neurotransmitter in Alzheimer's dementia. Also, in fact, activity of choline acetyltransferase is also reduced, which is one of the enzymes required in the critical step of the synthesis of acetylcholine. Then other neurotransmitters such as even norepinephrine, serotonin, they are reduced. And again, important to remember, excessive stimulation is there by glutamate, which may damage the neurons. So one of the important neurotransmitter which may increase initially is glutamate, and glutamate we know is an excitatory neurotransmitter. It causes excitatory damage. So these are some important neurotransmitter changes which occur. And in fact, when we'll talk about the treatment, we'll correlate all these etiologies which we have discussed with the treatment also. So we've talked about that acetylcholine is reduced. So we'll talk about a drug which increases acetylcholine. We've talked about that glutamate is increased. So we'll talk about one drug which is acting on glutamate receptor, is an antagonist. Also in Alzheimer's disease, we have talked about that there are A-beta deposits. So now in fact there is a new drug, in fact there is a new class of drug which we'll discuss, which help in the clearance of these A-beta deposits. So I always say, always remember the mechanism of action of drug and correlate with the etiology. So you don't have to mug up. So these are three important mechanism of action of drugs we'll discuss in the treatment of dementia. So now we'll talk about some important risk and protective factors for Alzheimer's disease. Now let's first talk about the risk factors, and risk factor we can remember with this mnemonic. So we know Alzheimer's disease, Alzheimer's dementia, it occurs in elderly, and elder people, they vote. So remember it with the mnemonic AD votes. So what is the, if somebody asks you which is the greatest risk factor of Alzheimer's disease, remember A for age. Age is the greatest risk factor. So with increasing age, the risk of Alzheimer's disease, it increases. Now let's discuss some other important risk factor. D, remember D for drugs. In fact, anticholinergic drug, as you know that in Alzheimer's disease we have discussed that there is decrease in acetylcholine. So any drug which would further decrease acetylcholine may also increase the risk. So some of the drugs include antidepressants like amitriptyline. Amitriptyline is a TCA, we'll talk about this, amitriptyline. Then even SSRI like paroxetine, that also has anticholinergic property. Even some of the other drugs like anti-Parkinsonism drug, even some of the drugs used in neurology like oxybutynin, all these drugs may increase the risk. Then next is V, V for vascular risk factor. Now even vascular risk factors, for example hypertension, hyperlipidemia, diabetes, smoking, these not only increase the risk of vascular dementia, but they may also increase the risk of Alzheimer's disease. Then next is O, O for oxidative stress. So oxidative stress can also increase the risk of dementia. In fact, studies have been done, for example, antioxidants such as vitamin E, even ginkgo biloba, these are antioxidants. Studies have been used whether they are useful for management of Alzheimer's disease, although studies have not given a definite answer, but we know yes that oxidative stress is an important risk factor. Then remember T for trauma, head trauma, or you can say traumatic brain injury. Traumatic brain injury, head trauma can also increase the risk of Alzheimer's disease. Now next is E, early life depression may also increase the risk of Alzheimer's disease. So somebody developing depression early in life may later on develop Alzheimer's disease. Also one more we can remember, that is environmental factors such as air pollution. So air pollution such as nitrogen dioxide, that can also increase the risk of Alzheimer's disease. Last is S, sleep disturbances can also increase the risk, and very important, earlier it was more of controversy, but now we know smoking is also shown to be an increased risk of Alzheimer's disease. So these are some important risk factors for Alzheimer's dementia. Now let's talk about some protective factors. Now in the protective factor, very important, high education level. So higher the level of education, it is shown to be protective. Now one of the mechanisms may be neuroplasticity. So it is seen people who have more formal years of education, that is more protective for them for Alzheimer's disease. Also remember Mediterranean diet. Now what is Mediterranean diet? A lot of plant-based diet, it also includes eggs, fish. So this Mediterranean diet has also shown to be a protective factor against Alzheimer's disease. So these were some important risk and protective factor of Alzheimer's disease. Now let's talk about the next very important dementia, which is Lewy body disease, or we can also call it as dementia with Lewy body, that is DLB. Now we already know that it is the second most common cause of dementia in older patients. It's also a neurodegenerative disorder just like Alzheimer's disease, and if we see the prevalence, it is slightly more in males, so predominant slightly more in males than females. Now when we talk about Lewy body disease, there is progressive cognitive impairment, but as we compare it with Alzheimer's disease, here memory impairment may not be that prominent in the early stage, it may occur in the later stage. And as we have discussed previously also, that Lewy body disease, both cortex and the subcortex may be involved, so it may have a mixed presentation. In fact, when we'll talk about the core features of Lewy body disease, we'll understand that both the features of cortex as well as the subcortex may be seen in the patient. Now we'll talk about the core features of Lewy body disease. Now there is some changes in the core features. In fact, the latest comprehensive textbook of psychiatry by Kaplan and Sedok, in the latest edition, they made some changes in the criteria. So let's understand some of the important core features. Now I'll give you a trick to remember. So we're talking about Lewy body disease. So let us say there is a person, Mr. Lewy, who is going for an interview to a body, to an institute. So what is the primary requirement? What is the core requirement of an interview? So this body is saying Mr. Lewy that show your CV, Mr. So they are asking show your CV, Mr. So we'll remember it with the mnemonic CVMR 1, 2, 3 and 4. We'll discuss 4 important core features. Now we have discussed that Lewy body disease has a mixed presentation. So let's correlate how these symptoms of cortex and subcortex we can remember in the core features. So first is C. So remember there is impairment in cognition and that too is fluctuating. Fluctuating means that the cognitive impairment, it is not stable. These may change over time. So symptoms may be more at some time, they may decrease after some time. So there is fluctuation of cognition and especially there is variation in attention and alertness. Now second is V. Remember V for hallucination, visual hallucination. In fact, we've talked about this, that which hallucination is more common in neurocognitive disorder? It is visual hallucination. In fact, it is one of the criterias in Lewy body disease. In fact, it is one of the core features. And these hallucinations, when we talked about Alzheimer's disease, there also visual hallucination would occur, but they would occur at a late stage. While in Lewy body disease, you may see that visual hallucination may occur at an early stage. And often we see that these visual hallucinations are more recurrent and usually more complex. That means they are more well-formed hallucination. So this is C is cognition, V for visual hallucination, then M. So we discussed that even the subcortical symptoms are seen, and when the subcortex is involved, we get a lot of motor symptoms. So as the core feature is telling you, M is motor features of Parkinsonism such as tremors, rigidity, bradykinesia. In fact, rigidity, bradykinesia may be more common than tremors in Lewy body disease. Now any of the one may be present to make the diagnosis. So there are motor features of Parkinsonism. Then this fourth entity, that is R, remember that has been now added. Earlier there were 3 core features, now there is another 4th core feature which has been added in Kaplan and Sadok. Remember R for REM sleep behavior disorder. Now we will discuss, and in fact we know that in REM the person may have vivid dreams which he remembers when he wakes up in the morning. And we also know that in REM usually there is atonia. That means when we are in REM, there is muscle paralysis. Now, sometimes there may be REM sleep behavior disorder. That means the person is in REM, but there is no atonia. So, person may have certain abnormal movements. They may act out their dreams. So, patient with REM sleep behavior disorder, they are having vivid dreams, and since there is no atonia, they may act out those dreams. So, they may have kicking, punching, such movements in sleep time. So this may also be seen in Lewy body disease. In fact, this may be one of the earlier presentation of Lewy body disease. So these are the 4 important core features of Lewy body disease. So again, sometimes this may be asked that REM sleep behavior disorder may be associated with which dementia. So it is Lewy body disease. So these are core features. Now let's talk about important supportive features of Lewy body disease. Now when we say supportive features, that means that if these features are present, it is supporting the diagnosis of Lewy body disease. First and very important supportive feature is severe neuroleptic sensitivity. Now what is neuroleptic? Neuroleptic means antipsychotics. So these patients are sensitive to antipsychotic induced side effects, especially EPS. Now first of all, would we like to give antipsychotics to these patients? Now we know that visual hallucinations can occur, which are psychotic symptoms, and we decide to give antipsychotics. So these patients are vulnerable to the antipsychotic induced EPS. So it's very important to remember that one should avoid antipsychotics as much as possible in the management of psychotic symptoms. If we have to give, we may give antipsychotics which have less EPS potential. We may start with low dose and we may rise or increase the dose slowly. So this is the first supportive feature. Second is that there may be repeated falls and there may be syncope. So repeated fall, syncope may be given in the history, and there may not be any focal neurological sign or symptom. They may just have patients with repeated fall, syncope. They may also have transient unexplained loss of consciousness. So again, these may be given in the question that patient is having these symptoms. Severe autonomic dysfunction may also be present, fluctuations in blood pressure, in the pulse rate, that may also occur. Also, there is a new diagnosis, new feature which has been added, hyper or hyposomnia. So there may be increase or decrease in the sleep. So hyper or hyposomnia may also occur, which has added a new criteria. Also remember, we have discussed that visual hallucination in the core feature, then hallucinations in other modalities like auditory, tactile, these may also occur in patients with Lewy body disease, and these are supportive features. Also, delusions may occur, and these delusions may be more systematized, that is, these may be more complex as compared to person having delusions in Alzheimer's disease. And delusions like delusion of persecution, even delusion of infidelity may be present, and very important, even Capgras syndrome we discussed in the delusional misidentification syndrome, close person replaced by strangers. And often patient with Lewy body disease may have this delusion. In fact, this has been asked previously that Capgras syndrome is associated with which dementia? So it is Lewy body disease. So many times, in fact, patient may come to us with this presentation that he is doubting that some of his family member, close person has been replaced by an exact double. So it's very important to remember this. Also, other symptoms like depression, even anxiety, apathy, these may also occur in the patient, and these are all supportive features of Lewy body disease. So it's very important to remember some of these important ones. For example, they are sensitive to the antipsychotics. There may be a lot of these symptoms, and also some other psychotic symptoms may also occur in patients with Lewy body disease. Now also, let's talk about the indicative biomarkers. So there are three important indicative biomarkers which we'll discuss now. First of all, we know that patient is having motor features of Parkinsonism, so we can expect that there is a decrease in dopamine in the basal ganglia. So first of the indicative biomarker is there is a decrease in the dopamine transporter uptake in the basal ganglia in the DAT scan, that is the dopamine transporter scan. Also, there is a decrease uptake in the metoidobenzyl guanidine myocardial scintigraphy. And one more important indicative biomarker, as we have discussed, that there is REM sleep without atonia. So in the polysomnographic report or in the polysomnographic test, we can find evidence of REM sleep without atonia. So these are some important indicative biomarkers of Lewy body disease. Also, in certain other investigations, let's discuss. So if we do a SPECT or a PET perfusion scan, generally we will find a low uptake with decrease in the occipital activity. Again, you can remember occipital region associated with the visual hallucination. And one very interesting sign also we can find in the FDG PET scan. Now this is very important interesting sign, which is also known as the posterior cingulate island sign. So here, as you can see in this FDG PET scan, what we can see that there is the uptake is decreased in the parietal, in the occipital region, but it is preserved in the posterior cingulate. So this is appearing like a island, posterior cingulate island sign. And in fact, sometimes it helps to differentiate in the early stages of Lewy body disease from Alzheimer's disease. So remember, posterior cingulate island sign may be seen on FDG PET scan in Lewy body disease. Also, when we talk about the pathology, what will you find in pathology? As the name suggests, we know that patient has Lewy bodies. What are Lewy bodies? These are spherical intracytoplasmic eosinophilic inclusion, and basically these are fibrillar deposits of alpha-synuclein. Now, when we see these Lewy bodies, how they appear on the microscope. So if you can see, so this is a Lewy body. Typically, it has a hyaline core, as you can see. So there is a hyaline core and it is surrounded by a halo. And again, these Lewy bodies can be seen in the cortex as well as in the subcortical regions like the brainstem. So in both these areas, it may be seen. Now also, these Lewy bodies, remember, they may also be seen in Parkinson's disease. So many times, patient with Parkinson's disease may also have these Lewy bodies. And sometimes very important to differentiate the dementia due to Parkinson's disease from dementia of Lewy body, because both of them may have overlapping symptoms. We've just discussed Lewy bodies may be seen in both of them. So it's very important to differentiate dementia of Lewy body, that is Lewy body disease with Parkinson disease with dementia. As both of them, since dementia is there, so cognitive impairment is present in both of them. Both of them can have visual hallucination, and both of them can also have motor features of Parkinsonism. And also we've discussed Lewy bodies may also be commonly seen in both. Now, one of the very important point to differentiate, in fact clinically we can differentiate by the temporal relationship between the onset of symptom, which symptom is occurring first. Now remember, in dementia of Lewy body, dementia would occur, cognitive impairment would occur in the beginning with or without Parkinsonism. So Parkinsonism symptom may occur in the beginning or may occur later on. While when we talk about Parkinson disease with dementia, here motor symptoms will occur first, followed by cognitive symptoms. In fact, in the research criteria, we use this 1 year rule. That means after the onset of motor symptom, 1 year later, the cognitive symptoms occur. So sometimes by this temporal relationship, we can differentiate Lewy body disease from Parkinson disease with dementia. Now, in fact, a very famous actor, Robin Williams, and which we know that he unfortunately died because of suicide. In fact, it was during my residency days when I heard this news. And again, you know, this actor had a great impact in our childhood. So many memorable movies we have seen of this actor. And you know, when he died and when autopsy was done, it was seen that his brain had diffuse Lewy bodies. In fact, prior to his death, he was diagnosed with Parkinson disease. So it seems that he was suffering from dementia of Lewy body, and in dementia of Lewy body, as we have discussed, a lot of other neuropsychiatric symptoms like depression, anxiety, paranoia may occur. And again, it's very difficult to sometimes differentiate dementia with Lewy body with Parkinson disease dementia, and maybe his actual diagnosis was dementia with Lewy body. So this was about Lewy body disease. So now we'll talk about the next dementia, which is vascular dementia, also sometimes referred to as multi-infarct dementia. Now, as the name suggests, here there is some vascular event which occurs. Now, normally we have discussed that most of the dementias, they have insidious onset, a gradual onset, and this is one of the dementias which may have a sudden or an acute onset. So, as the name suggests, it results from stroke. Again, stroke is sudden loss of blood supply to an area of the brain, which leads to some permanent damage. Now, this stroke, it can be ischemic. So, ischemic means that there is a stoppage of the blood flow. So, it may be because of occlusion of vessels by arteriosclerotic plaque, or it may be because of thromboembolism. So, there may be ischemia, or there may be hemorrhage, there may be bleeding in some area of the brain. Now, when we talk about the vascular dementia, so vascular dementia will be more common in males or females. So, we can remember it like this: vascular events, they occur more commonly in males. So, remember, vascular dementia is more common in males than females. Now, also when we talk about the risk factors, a lot of vascular risk factors will also be risk factors for vascular dementia. For example, somebody having pre-existing hypertension, even hypotension may also be a risk factor. Also, other cardiovascular risk factors, for example, hyperlipidemia or diabetes mellitus, or person is smoking cigarette. Then even heart disease, especially atherosclerotic heart disease, they may also increase the risk of vascular dementia. Now, also in vascular dementia, as we know, when the patient comes to us, there may be sudden onset of symptoms, and imaging is a very important modality in the investigation, and often we find some area of the brain having infarct or there is hemorrhage. So, we can find that in the brain imaging. Like in this case, we can see on the MRI scan, we can see that there are bilateral intraparenchymal hemorrhage. We can see, you know, multiple white matter hyperintensities, as we can see in this image, which is suggesting of the multiple infarct in the white matter. So, this is, you know, one of the important modalities in the assessment is imaging. Now, also when we talk about the presentation of symptom, there is sometimes a very interesting pattern seen in vascular dementia, that is known as step ladder pattern. Here there is stepwise deterioration of symptoms. Now, there may be sudden acute exacerbation of symptoms which may correspond to the area where the stroke has occurred. So, each time another event would occur, another stroke would occur, and there would be acute exacerbation of symptoms. So, let's understand what is it. So, for example, let us say somebody had a stroke at some time in their life, and suddenly after the stroke there is increase in symptoms, and after some time the symptoms may come to a plateau. Let us say after some time another stroke occurred, so again suddenly the symptoms will rise, and after some time let us say they come to a plateau. Again after some time the symptoms may again occur when there is a stroke and they come to a plateau. So this presentation, this pattern is known as step ladder deterioration, which may be seen in vascular dementia. Now in vascular dementia also we know that along with the cognitive symptoms, there may also be certain focal neurological signs and symptoms which usually would correspond to the site of insult. So wherever any part of the brain which is affected, even there may be focal neurological signs symptoms related with that part. So there may be paralysis, there may be paraplegia, there may be some difficulty in movement of any of the limb, there may be extensor plantar response may be there. So there may be any area which is affected that may also show certain focal signs and symptoms. And as we have discussed that vascular dementia may have a mixed presentation. So again, vascular event may occur in the cortex or in the subcortex. So it may have a mixed presentation. Now coming to the treatment of vascular dementia, it's important to manage the vascular health such as managing blood pressure, cholesterol, blood sugar. So these are important part in the management, and of course we would also manage as done in medicine or in surgery, we will also manage the stroke accordingly. So this is about vascular dementia. Now let's discuss the next dementia, that is frontotemporal dementia, also sometimes referred to as pig disease. As the name suggests, frontotemporal dementia means it is having atrophy of the frontal and temporal lobe. Again, many different types of dementia may be there. Pig disease is one of them. Again, what is the characteristic of all these frontotemporal dementia? That there is atrophy of the frontal and the temporal lobes. So these regions will have neuronal loss, there may be gliosis, and pig bodies may also be seen. These are masses of cytoskeleton elements. Now again, these are more common, slightly more in males than females, and as we've already discussed, it is the second most common cause of early onset dementia. So the onset is usually in earlier age. Now in early stages, especially in frontotemporal dementia, remember there are more of behavioral changes, personality changes, even language impairment may also be seen initially, and relatively when we talk about cognitive functions, they may be relatively preserved in the beginning, like memory, they may be affected later on. So remember, in frontotemporal dementia, a lot of behavioral, a lot of language impairment symptoms may occur in the beginning. In fact, a very famous actor, Bruce Willis, he, again, we have so much memories of watching his movies like, Die Hard series, The Sixth, and so many movies we've seen him. And recently he was diagnosed with frontotemporal dementia. In fact, before the diagnosis, initially, when he retired from the movies in 2022, one of the reasons was because he had developed aphasia. Aphasia, there is language impairment. And later on, in fact, he was diagnosed with frontotemporal dementia. So we can understand this, that yes, language impairment may also occur in the initial presentation. Now there are two variants. Again, we can remember the two variants from Bruce Willis's name. So we can remember, so Bruce Willis with double S. So remember, there are two variants. One is B for behavioral variant, and there are double LL is there in Bruce Willis language variant. Now behavioral variant and language variant, in fact, you can remember they correspond to which area is getting affected more. So in the behavioral variant, it is the frontal lobe which is getting affected more. So in frontal lobe, if that gets affected, a lot of behavioral symptoms may occur. For example, disinhibited behavior. Now normally we have certain inhibitions. For example, if you are sitting in a class and you want to dance, it's not like you will stand up on the desk and you will start dancing. Of course, you will wait for the class to get over. Maybe you'll go to a party and you'll dance. So we have certain inhibitions. But if frontal lobe is affected, we say these inhibitions are lost. So patient may have certain disinhibited behavior. For example, a person goes out in public and starts urinating without any guilt. So again, not just in frontotemporal dementia, in fact, you can remember that whatever be the cause, if frontal lobe is affected, the person may develop some of these important symptoms. So one is, there may be disinhibited behavior, socially inappropriate behavior. Then apathy, lack of concern for others, that may develop. Even stereotypic, certain abnormal, non-purposeful movements may also occur. and even hyperorality. Everything taking in the mouth, whatever the person sees, put in the mouth. Hyperorality may be seen. So these are some of the important signs and symptoms which can occur. Remember, if frontal lobe is affected. So even in behavioral variant of frontotemporal dementia, you may find such symptoms. Now the second variant is the language variant, and this corresponds to the temporal lobe atrophy. So in language variant, it is more of the temporal lobe which is affected. Now again, there are various types of language variant. One is semantic variant. Now as the name suggests, there is problem in the semantic part of the language. So there is impaired naming, word comprehension is difficult. Sometimes the person may use the word food for various objects like apple, sandwich, and later on when it becomes even more severe, he may just use the word things for different object. So there is problem in the semantic part of the language. Then another is progressive non-fluent aphasia. Here the person is having a lot of problem in fluency in grammar. So inability to produce words, grammatical errors the person will make. Now we talked about this, that the frontotemporal dementia is more common in males than females, especially the behavioral variant and even the semantic variant. They are more common in males than females. And remember, the progressive non-fluent aphasia, that is more common in female than males. So remember this, that difficulty to produce words, grammatical errors, this variant is more common in females. Now let's talk about the pathology. Pathology, as the name suggests, in frontotemporal dementia, also known as PIC disease, we find these PIC bodies. So PIC bodies, these may be seen, and also remember that there may be certain inclusions which are seen. There may be T positive inclusions, including which includes PIC disease. Then there may be T negative ubiquitin P62 positive inclusions which include TDP 43 positive inclusions. So this is also sometimes how we can divide frontotemporal dementia: T positive inclusions, T negative, ubiquitin P62 positive inclusions. Now also when we talk about the management, in fact in the management of frontotemporal dementia, SSRIs are usually the first line drug. Again, they are not FDA approved, but usually these are the first line drugs in the management of frontotemporal dementia, because we see a lot of behavioral symptoms are there. Now also there is no approved drug for cognitive deficit in frontotemporal dementia. So this was about FTD, that is frontotemporal dementia. Let's discuss some other dementias. Next is prion disease. Now prion disease, again we know, is caused by prions, which are infectious proteins. They are basically misfolded prion protein, and usually there is a rapid progression of prion disease, and initial symptoms may be memory impairment, there may be confusion, and in many of the variants there may be also ataxia, myoclonus, that may also be seen. Now there are various prion disease. Let's discuss some of them, and you can remember it with the mnemonic CVKGF. So I'm sure you might have seen the movie KGF. Remember CVKGF. So C is Creutzfeldt-Jakob disease, CJD. Then V is, there is a variant of CJD, also known as mad cow disease. Then Kuru with the double U. Then G is Gerstmann-Straussler-Skinner disease, GSS, and F is fatal familial insomnia, FFI. So these are some important prion disease. Now let's discuss the next type of dementia, that is NPH, normal pressure hydrocephalus. Now we talked about this. This is in fact one of the reversible causes, and here in fact there is a triad of symptoms, three important symptoms. First, of course, there is dementia. Again, usually it is mild to moderate, with emphasis more on the executive impairment is more there. Then second is abnormality of gait. So patient may fall repeatedly, the gait is abnormal, and many times we see this characteristic magnetic gait is seen. So it is basically low foot clearance. The foot comes very less height from the floor, and as if it is the floor has a magnet. So it is again as if there is magnet on the floor, and very low height gait is there. So magnetic gait, and also patient may have urinary incontinence. In fact, this triad sometimes is known as Adam's triad or Hakim's triad. So this triad sometimes is known as Adam's triad or Hakim's triad. Coming to the management, as we know, it is reversible. So ventricular shunting is one of the treatment modalities for NPH. Now, some of the other dementias as we have discussed, like Huntington's disease, Parkinson's disease, Wilson's disease, multiple sclerosis, in fact even others like PSP, progressive supranuclear palsy, these we know these are subcortical dementia. And a lot of these dementias initially would present with a lot of motor abnormalities. In fact, you read them in medicine in more detail. So remember, even in these causes there may be development of dementia. So it is subcortical dementia. Then even HIV infection can cause dementia, which is known as HIV related dementia or AIDS dementia complex. Here diagnosis is made by the laboratory evidence of systemic HIV, and cognitive deficits may occur in the patient, a lot of motor abnormalities may occur, and even personality changes can occur, such as apathy, lack of concern, emotional lability may be there, and even behavioral disinhibitions can also occur in HIV related or dementia or AIDS dementia. And again, it is usually progressive, may ultimately lead to death. Then next, one more dementia which we can discuss is head trauma related dementia. As the name suggests, there is head trauma which is causing dementia. Many times we see repeated head trauma can lead to later on dementia. It is also known as dementia pugilistica, as it is again commonly seen with boxers, also known as punch drunk syndrome. So this may occur in boxers after repeated head trauma because of years and years of their boxing career. They may have minor head traumas and ultimately they may develop dementia. And patient may have emotional lability, dysarthria, impulsivity. These behavioral abnormalities may also occur. In fact, nowadays they are also being seen in footballers again because they kick the ball with their head as well. And a lot of injuries may occur during the play. So this is head trauma related dementia. Now let me discuss a relatively newer diagnosis. In the textbook, relatively newer diagnosis has been added and you can remember it with the mnemonic late. So what is this late? It is limbic predominant. So when we talk about this late dementia, it is limbic predominant. So hippocampal atrophy may be seen. Hippocampal atrophy we know also occurs in Alzheimer's disease, but in this dementia it may occur early. So hippocampal atrophy may be earlier in late than Alzheimer's disease, and hippocampal sclerosis may also occur. Then age related means here it occurs especially later than 80 years of age. It is more common in people with more than 80 years of age. So it is limbic predominant, age related, TDP43. So TDP43 protein inclusion bodies, which also can occur even in frontotemporal dementia, but that was, we know it occurs usually in an earlier age. So TDP43 protein inclusions occur in this late dementia. So these are some important points. So again, when we talk about these TDP43 inclusion bodies, since it is limbic predominant, it starts with the amygdala and it may subsequently also be seen in the hippocampus and then subsequently other areas, and hippocampal sclerosis, as we discussed, that may also be seen in this dementia. So hippocampal sclerosis may also occur. So this is again a relatively newer diagnosis. Remember, late, limbic predominant, age related, TDP43 encephalopathy. Now also, in fact, sometimes depression can lead to cognitive dysfunction. So let's discuss depression related cognitive dysfunction. Now as we know, in depression many times patient may come to us with symptoms of forgetfulness. I am forgetting things. But this forgetfulness usually when we explore, it is more of because of decrease in concentration. There are so many negative thoughts which are going in the mind that person does not concentrate in the current situation, and the person may think that he is not remembering things. So in fact it is also sometimes termed as pseudo dementia. Now in pseudo dementia, again, as we know, depressive symptoms will be more prominent. And how to differentiate this from, let us say, dementia in Alzheimer's disease? Here there is more insight into the symptoms. So patient will accept, yes, I am forgetting things. Patient has an awareness that I am forgetting. Patient may in fact come and say, I am forgetting things. While in Alzheimer's disease, we often see that the patient does not have that insight. They may in fact, when we say that you are forgetting things, they may start arguing, no, I am not forgetting. But here the person will accept, yes, I am forgetting things, and they will not try to hide. While in Alzheimer's disease, the person may try to hide that he is forgetting things. So this is one very important point to differentiate. And also for pseudo dementia, we may not require any specific treatment. We treat depression in fact pseudo dementia will also be treated. So usually antidepressant may be used in the management. So this is depression related cognitive dysfunction. Now let's discuss how to assess a patient with dementia. Now we would like to investigate the patient, especially we would try to find the cause in patient with dementia. For example, in patient with dementia, we may like to do thyroid function test. As we have discussed, hypo or hyperthyroidism can cause dementia. So we would like to do those tests depending on what we are suspecting as a cause of dementia. We may also like to do vitamin B12 levels. As we know, deficiency of vitamin B12 can cause dementia. We may also like to do HIV testing of the patient if we are suspecting that as a cause. Again, in patients with vascular dementia, we would also like to monitor the blood pressure and other vascular parameters in the patient. We may also like to do brain scan in patients with dementia. For example, in vascular dementia, we may get some findings in the brain scan. Also in Alzheimer's disease, we know there may be diffuse atrophy on MRI, especially the parietal and the temporal lobe. So depending on the cause, we would do the basic assessment. Now let's discuss assessment of cognitive domains. Again, there are certain tools which we can use to assess the cognitive domains. One such tool is MMSE. What is MMSE? Mini Mental State Examination. Again, don't confuse this with MSC. MSC is mental state examination. It is a assessment of any psychiatric patient comes to us. While MMSC is a screening tool which helps us in the assessment of the cognitive functions. This MMSC, again, as we discussed, is a screening tool, and there are various questions, there are various tasks which we perform with the patient, and we get a total score is 30. And any score less than 24, that is 23 and below, it is suggesting that patient may be having dementia. Again, it is not a definitive diagnosis, but this may suggest patient has dementia. This was given by Falstein et al. Let's discuss some of the important domains which are assessed in MMSE. The first is we assess orientation. Again, a total score of 10 is there, and we assess parameters such as we ask the patient what is the year, the season, day of the week, month, date, and again each is given 1 mark each. Subsequently, we also asked what is the state the person is right now, what is the country, town, the hospital, and which floor the person is right now. So again, we get a total score of 10. Then we assess registration. In registration, we ask 3 unrelated objects and we allow 1 second for each of the object to say. For example, we may tell the patient apple, red, happy, and the patient has to repeat all the 3, and if one is correct, we give 1 mark each to the correct answer. So then we get a total score is 3. Then next is we assess the recall. So the 3 words which we have asked the patient, we ask them 5 minutes later. Again, 1 mark each is given to the correct answer. So again, a total score of 3 is given. Then we assess concentration. Again, we have talked about this. What is concentration? It is sustained attention. And how do we assess concentration? We ask again 100 minus 7 test is given, and up till 5 times if the person is able to make it correct, we say it is normal. So again, 1 mark is given to each of the correct answer. Also, there is another test for checking concentration. We can ask the patient to spell the word world backwards. So he has to spell this word, that is world, which is again a 5-letter word. So he has to spell it backward. Again, we give each 1 number if it is correct. So total score of 5 is there in concentration. Then lastly, we assess language. Again, it is not just language we assess, we also assess various other cognitive functions, for example, executive functions. So let's discuss what are the important tests which are done in assessment of language. First is we show the patient wristwatch and we ask the patient that what it is, and he has to tell us. And similarly, we ask him to repeat, we show a pencil and say what is this. So then again 2 marks are given to this. Then we ask the patient to repeat the following sentence, that is no ifs and or buts, and again if he is able to do this, we give 1 point. Similarly, we ask the patient, we give a 3-step command to the patient. For example, we tell the patient to take a piece of paper in your right hand, fold it in half and put it on the floor. Again, if the person is able to do all these correct, so 1 part is given to each of the steps. Then we ask the patient to read and obey the following sentence. So we write a sentence on the piece of paper, he has to read and he has to obey it. For example, we write this, close your eyes. So he will read a paper in which close your eyes is written and he will close the eyes. So again, 1 point is given for that. Then we ask the patient to write a sentence which has at least one noun and one verb. If it is correct, then 1 point is given. And lastly, the patient is asked to copy this design. Again, if he is able to, 1 point is given. So as you can appreciate, a total of 30 marks is there in this MMSE. And if a person scores less than 24, we say that it is suggesting of dementia. Now again, please remember, this MMSE is for basically assessment of cognitive function. Sometimes it may also be used in delirium, because we know even in delirium there is cognitive impairment. Then there are other tools which may be used for assessment of cognitive domain. So one is MMSE. One more you can remember, that is MOCA, that is Montreal Cognitive Assessment. So these are the tools which are used for assessment of cognitive functions. Now also, let's discuss that there are also certain tools to assess impairment, that is cognitive and functional impairment. Two such tools you can remember. One is CDR, that is Clinical Dementia Rating Scale, and the other is FAST, that is Functional Assessment Staging. So these are assessment tools to assess the degree of impairment. Now let's talk about the management. When we talk about management of any patient with dementia, it is individualized. It will depend on person to person, what is the case we are dealing with, and sometimes we may use multimodal approach. So different approaches may be used in management of a patient with dementia. Now first point in the management is treat the cause. Now why we are saying treat the cause? Because we know usually dementia, it is progressive, but there are certain patients who may have a reversible cause. So it's very important to identify if our patient is having a reversible cause of dementia, because if he's having a reversible cause, if we treat it, dementia may be reversed. Otherwise, we know usually it is progressive. Now, in the management of dementia, we have first is management of the cognitive symptoms, and secondly, we'll talk about management of the neuropsychiatric manifestations. Now, in the management of cognitive symptoms, again, we have two modalities. One is non-pharmacological approach. Usually we may start with those approaches, and if required, we may also use drugs. Now in the non-pharmacological approaches, first is CBT, that is cognitive behavior therapy. So CBT may be used, and depending on certain symptoms, we may use CBT. Another important non-pharmacological strategy which may be used for dementia is the reminiscence therapy. Now what is this reminiscence therapy? This allows the patient to recall and relive his past events. So basically it stimulates the mood, the memory of the person, and this may give us short-term gains, especially in patients who may appear confused, who may be irritable. In those patients especially, we may use this reminiscence therapy. Then we may also use behavioral management. Now in behavioral management, sometimes we have certain problematic behavior in the patient, and we may identify the antecedents. What were the antecedents which led to that behavior? And subsequently, by modifying those antecedents, we can modify the behavior. For example, sometimes patient may become irritable. He is not able to find the washroom because there is deficits in memory, and he is having urinary incontinence. So in this patient, we may do toilet training, we may take the patient frequently to the washroom, and subsequently that irritable behavior may decrease. So behavioral management may also be used. Then next is cognitive retraining. In cognitive retraining, cognitive skills training, we know cognitive deficits are there. So cognitive skill training exercises may be used especially for improving orientation, concentration. So we may target certain cognitive deficits. And lastly, important, psychoeducation. Now, psychoeducation of the patient as well as the caregiver is very important. We may have to, explain about the disease process and what is the course, what is the prognosis. All those things need to be told. And many times we see that there is caregiver exhaustion or caregiver burden. It's important to also include the caregiver in the management. So these were some non-pharmacological approaches. Now let's talk about the pharmacotherapy. Now the drugs which we are going to discuss, especially these are approved for Alzheimer's disease. Now we have talked about the etiology in Alzheimer's disease, and let's try to correlate the etiology with the management. So we know in the etiology there was decrease in acetylcholine. We talked about there was increase of glutamate, and especially for Alzheimer's disease we also know that there are A-beta deposits in the brain. Now let's try to understand the drugs, and we can correlate with the etiology. So we know that there is a decrease in acetylcholine, so we'll use a drug which will increase acetylcholine. We'll use a drug which is antagonizing glutamate receptor, and there are some new drugs which help in clearance of these A-beta deposits. So the first category of drug which we will discuss are the choline esterase inhibitors. Now as the name suggests, what are these drugs? These drugs are reversible inhibitors of the enzyme acetylcholine esterase. Now what is this enzyme doing? This enzyme basically metabolizes acetylcholine into acetyl-CoA plus choline. Now if we inhibit this enzyme, so what will happen? There will be increase of acetylcholine, and that is what is required. As we know, there is a decrease in acetylcholine in dementia. Now these drugs especially, they are approved for the management of Alzheimer's disease. As we discussed, most of these drugs we'll talk about, they are approved for Alzheimer's disease. Now first drug in this category is tacrine. Now it is not used much nowadays because of one important side effect, that is it can cause hepatotoxicity, and also it has to be given 4 times a day. So tacrine is one of the drugs which is not now very commonly used. Let's discuss some other very important drugs. So you can remember these drugs with my name, Dr. Goyal. So what is D? D is donepezil, and donepezil usually we start with 5 mg and maximum dose is 23 mg. Then second is rivastigmine, and third you can remember is galantamine. Now when we talk about these cholinesterase inhibitors, let's try to discuss some of these side effects. As we know, they are increasing the acetylcholine, so the side effects are also related with the increase in acetylcholine. So patient may have GI side effect because of increase in the acid secretion. These patient may also have bradycardia with syncope because of again increase in the acetylcholine. And again one has to be cautious when we are using these drugs. We have to be cautious in some of the disorders. For example, in gastric ulcer disease, one has to be cautious when we are giving this drug. Even in sick sinus syndrome, we have to be cautious. Or if there is any conduction defect, so in any cardiac issue in conduction defect, again one has to be cautious when we are using these drugs. Also for asthma or COPD, one has to be cautious, and also in cerebrovascular disease. So these are some conditions one has to be careful, especially since we are giving it in elderly. Many times we see that these disorders may be seen in elderly. So one has to be cautious when we are giving these drugs in patients having these diseases. Also when we talk about donepezil, donepezil is the only cholinesterase inhibitor which is also approved for severe Alzheimer's disease. So the other drugs, that is rivastigmine, galantamine, are also approved, basically approved for mild to moderate condition, while donepezil is one of the drugs, especially donepezil, when we talk about all these drugs, it is only the drug which is approved for all the stages, that is mild, moderate and severe Alzheimer's disease. Also, as we have discussed, sometimes patient may also have severe GI side effects. So many times, this is asked also, that if the patient develops severe GI side effects, then which drug we may switch to. So we may switch to a drug which can be given through other route than oral route. So remember, rivastigmine is one of the drugs which is also available as a transdermal patch, and this has been also in fact asked previously in one of the exams. Also remember, now if the question again is asked, again we can go with rivastigmine, but also remember, even donepezil has been now approved by the FDA for used in the transdermal patch. So these are the drugs which are now available as transdermal patch, but again if the exam comes, and since books still mention rivastigmine, you can go with rivastigmine, which is used as transdermal patch. Now the second drug which we will discuss is mementin. Now what is mementin? It is NMDA, N-methyl D-aspartate antagonist, non-competitive antagonist. Now let's understand what is NMDA. NMDA is basically glutamate receptor. So again we can correlate this with the etiology. We know that glutamate is increased in dementia, and we are using a glutamate receptor antagonist, NMDA antagonist. So mementin is another important drug which can be used. Now it is used especially for moderate to severe Alzheimer's disease, not used in mild cases. And also remember, it can be used as a monotherapy, and also it can be used in combination with donepezil. In fact, in market, the combination of donepezil and memantine, they are also available. Donepezil, again, we start with 5 milligram and maximum dose is 20 milligram, and it is metabolized by the renal route. Now, in fact, in India, we have these two drugs, that is cholinesterase inhibitors and memantine. Now, let's discuss that these drugs are, of course, we have talked about they're used in Alzheimer's disease for cognitive symptom, but they can also be used in some other dementias, although they are not approved. But they can be used in other dementias like Lewy body disease, especially drugs that is donepezil and rivastigmine, and also can be used in dementia like vascular dementia for treatment of cognitive symptoms. Now let's discuss one more important newer category of drugs, which are monoclonal antibodies. So these are new drugs which have been approved recently by the FDA. Now these are monoclonal antibodies and they specifically target one specific antigen, that is they are directed towards A beta deposit. Now where A beta deposits are occurring? It is occurring in the Alzheimer's disease. So these new drugs especially, they are used for Alzheimer's disease. They are also sometimes referred to as disease modifying therapy. So FDA has approved these drugs for mild cognitive impairment. We'll discuss what is mild cognitive impairment. It is a milder form of cognitive impairment and sometimes maybe referred to as a prodromal phase to the dementia. And so it can be used for mild cognitive impairment or the mild dementia stage of Alzheimer's disease. So it is only used for these conditions. So when we talk about these drugs, there are 3 drugs and we will remember it with the name Alzheimer's disease. So we know that these drugs are used only for Alzheimer's disease. So remember A, L and D. So there are 3 drugs and we can remember it like this. One is aducanumab, L stands for lecanemab, and remember D is donanemab. Now these drugs are basically used as IV infusion. Now let's discuss the first drug, that is aducanumab. Can you remember the name? Yes, you can. Now these are, MAB means these are monoclonal antibodies. So in fact these are human IgG1 monoclonal antibodies. They are basically directed towards A beta deposit. Again, from the name itself you can remember AD, that is remember for Alzheimer's disease. Now these drugs were approved by the accelerated process by the FDA, but again the efficacy of these drugs may still be questionable. Now the second drug which we are going to discuss is again important, lecanemab. Can you remember the name? Again, yes you can. So again it's a MAB, that is monoclonal antibody, and it is in fact humanized IgG1 monoclonal mouse antibody. Now this has been approved both through the accelerated process and also through the traditional process of the FDA, and this is one very important drug which has shown in studies improvement in cases of Alzheimer's disease. Now let's talk about some common side effects of these drugs. One is headache and second is infusion related reactions can occur as these are given through IV infusion. And another important side effect which you can remember, again sometimes they may ask these as new questions, ARIA. What is ARIA? Amyloid related imaging abnormalities. So these drugs may cause brain swelling or they may cause brain bleeding. So because of these ARIA side effects, there has to be regular brain scan monitoring need to be done when we are giving patient lecanemab. So remember, lecanemab is an important drug which is used for Alzheimer's dementia. This is approved by the FDA in 2023. Now more recent drug remember is donanemab. In fact this drug got approval in 2024. And as the name suggests, it is also a monoclonal antibody. It is also humanized IgG1 monoclonal mouse antibody. So these are 3 important monoclonal antibodies which have been approved by the FDA for management of Alzheimer's disease. Now let's talk about the treatment of neuropsychiatric manifestations. As we have discussed, many of the patients having dementia may also have these behavioral and psychological symptoms. So when we manage these symptoms, the approach is first we use non-pharmacological methods and if required we use drugs. Now in the management, let's first talk about management of agitation, delusion, hallucination. Let's talk about management of agitation and some of these psychotic symptoms. Now in the management of these symptoms, first in the non-pharmacological approach, we use the DICE approach. Now, what is this DICE approach? D is we describe the problematic behavior. What is the behavior? We describe it. Second is we try to investigate the causes, and there may be certain modifiable causes which may be there. Then C is we create a plan and we implement that plan, and E is we evaluate whether that plan is effective or not. So this is again, remember, the DICE approach which is used for management of these symptoms. Now, coming to the drugs, so antipsychotics, especially the second generation antipsychotics, for example, risperidone, olanzapine, quetiapine, aripiprazole, these are some of the drugs which have been studied in management of these symptoms, and especially as we know that second generation drug may have less EPS. Now also remember, clozapine is one of the drugs that has been used in the management of psychotic symptoms in Parkinson disease, and similarly even in dementia of Lewy body they may be used because of lack of EPS. Now also there is a drug, a newer atypical antipsychotic, that is pimavanserin. Again, how to remember the mechanism? It is a inverse agonist. Ser means serotonin, and this drug is having in the name 2A. So remember, it is 5-HT2A inverse agonist, and it is the antipsychotic which is approved for management of psychosis in Parkinson disease dementia. As we know, in Parkinson disease, patient already has a lot of motor side effects, motor symptoms. So when we give some of the other antipsychotic, they may increase those side effects. So this is one of the drugs which is approved by the FDA for management of psychosis in Parkinson disease dementia. Also a new drug, remember, brexpiprazole. Now, brexpiprazole again is a second generation antipsychotic. It's similar to aripiprazole. So this drug is also a partial D2 agonist, and again this drug has been recently approved by the FDA for important condition, that is agitation associated with dementia due to Alzheimer's disease. Now before this approval, if somebody would ask what is the management of agitation in patient with Alzheimer's disease, we would say antipsychotics we can use, second generation antipsychotics maybe we can use. But now for specifically agitation in patients with Alzheimer's disease dementia, there is a drug which is approved, that is brexpiprazole. Now when we are managing these symptoms, so again we usually don't use first generation drugs like haloperidol because there is a greater risk of EPS, extrapyramidal symptoms. Also remember, whenever we are using antipsychotics in elderly patients, so these patients usually are elderly patients in which we are managing these symptoms, antipsychotics may be associated with the increased risk of cardiovascular events and mortality in elderly. So all these antipsychotics, remember, they may be associated with the increased risk of cardiovascular events or mortality in elderly. Now let's talk about the symptoms such as depression, anxiety. So again, for managing symptoms such as depression, anxiety, antidepressants may be used, especially drugs like SSRI, that is selective serotonin reuptake inhibitor. And also we have discussed that these SSRIs are also used in the management of frontotemporal dementia. Now also benzodiazepines may be used for managing symptoms like agitation, insomnia again, but one has to be careful as too much sedation may cause falls, may cause injury in these elderly patients. So this was about the management of dementia. Now the next neurocognitive disorder, that is the third neurocognitive disorder which we'll discuss, is amnestic disorders. Now from the name itself we can understand, so what is amnesia? So in amnestic disorder there is memory impairment. Now let's try to again remember these important neurocognitive disorders. So we have discussed delirium, we have talked about dementia, and now we are discussing amnestic disorders. So again let's try to understand this transition. In delirium we discussed both consciousness as well as cognition, they are impaired. When we discuss dementia, in dementia only there is cognitive impairment, and in amnestic disorder we are saying out of the cognitive domains it is only the memory which is getting affected. So remember this transition and we'll be able to remember these important neurocognitive disorders. So in amnestic disorder, there is memory impairment, especially recent memory is impaired. So the person is not able to learn new information. That is, there is anterograde amnesia. And also there is reduced ability to recall the past events. So there is also retrograde amnesia. Now let's discuss what all things are intact in amnestic disorder. Now first is immediate memory is intact. Second is consciousness is intact. Now if consciousness is impaired, then diagnosis will not be amnestic disorder. Diagnosis will change to delirium. And also global intellectual decline, that is also not there. So other global intellectual functions, they are also intact, because if other cognitive symptoms are also affected, then diagnosis will change to dementia. So remember, in amnestic disorder, there is memory impairment. Now coming to the causes of amnestic disorder, there may be so many causes. There may be CNS causes, there may be systemic causes. So in CNS causes such as seizures may be there, head trauma, hypoxia, tumors, even ECT, electroconvulsive therapy. In ECT, of course, we'll discuss, there is a transient amnesia. And even in multiple sclerosis. Now coming to systemic causes, one very important cause which I want you to remember is thiamine deficiency. Now sometimes even alcohol use can lead to thiamine deficiency, and that leads to one very important syndrome, that is Korsakoff syndrome. So Korsakoff syndrome, which is alcohol induced, it is because of deficiency of thiamine that can cause amnesia. So remember, when we'll discuss Korsakoff syndrome, I'll discuss which is one very important symptom. So you'll say, sir, amnesia. That is, patient may have amnestic disorder. Then even hypoglycemia, even substance related like alcohol, benzodiazepine. So these are some important causes of amnestic disorder. Coming to the treatment, again, we'll treat the underlying cause, and also psychotherapy may also be used. Now we have talked about some important neurocognitive disorders. Let's discuss some other relevant topics related to them. So the next heading which we are going to cover is mild neurocognitive disorder, also sometimes referred to as MCI, that is mild cognitive impairment. Now before discussing what is MCI, let's understand what are activities of daily living. As the name suggests, there are certain activities which we do for a daily living, and again we can broadly classify them as basic activities of daily living and instrumental activities of daily living. So basic activities would include activities such as dressing, such as bathing, feeding, toileting. So these are all very basic activities of daily living. While when we talk about instrumental activities of daily living, these include activities such as using a telephone, then meal preparation is also a instrumental ADL, then even financial management or medical and even financial management. These are again all instrumental activities of daily living. Doing your laundry, even other activities like shopping, these are all instrumental activities of daily living. So remember these basic activities of daily living and instrumental activities. Now let's talk about what is MCI. Now in MCI, as the name suggests, mild cognitive impairment, we are saying that there is a modest cognitive impairment in one or more of cognitive domains. While we discuss this in dementia, in fact, there is a significant impairment. But here we are saying that it's a modest impairment, not very severe. And also, these impairments, they do not interfere with the instrumental activities of daily living. Even if they interfere, the person is able to compensate for it by making some extra effort. While again, if we talk about dementia, or as we call it as major neurocognitive disorder, we discussed that there is interference of activities of instrumental activities of daily living, and also especially remember, they do not interfere with basic ADLs. While in dementia, there may be interference with even the basic ADLs in later stages. So remember, mild cognitive impairment, as the name suggests, we are saying that there is mild cognitive impairment, and subsequently because of this, the interference is not that much in activities of daily living. Now when we talk about the mild cognitive impairment, sometimes it may represent a prodromal stage. So sometimes before the person develops even mild Alzheimer's disease, there may be a prodromal phase which may be MCI. So it may be a prodromal stage. But remember that all the patients who are having MCI, they may not eventually develop dementia. So this is important to remember. that every patient who has MCI may not eventually develop dementia. So this is mild neurocognitive disorder or MCI. Now also let's discuss one important interesting entity, that is frontal lobe syndrome. Now frontal lobe, as we all know, it is the largest lobe of the human brain, and if frontal lobe is affected, it may lead to disorders of cognition. For example, there may be slow thinking, it may lead to mood symptoms like irritability, there may be abnormalities in motivation, there may be decrease in motivation, even behavioral control, there may be impulsivity. So a lot of these abnormalities can occur if frontal lobe is affected, and this frontal lobe may get affected because of various reasons. For example, it may get affected because of trauma, there may be tumor, or if there is an infarct, even in lobotomy, even in surgery, sometimes these are affected, even in multiple sclerosis, and again remember, we have talked about this even in Pick's disease. So there is frontal lobe involvement in frontotemporal dementia. Even in those cases, frontal lobe may get affected. Now, when we talk about frontal lobe, especially remember in bilateral lesions of frontal lobe, sometimes patient may have bilateral lesions of frontal lobe. This may lead to changes in the person's personality. What is personality? Personality means how the person interacts with the world. So there may be personality changes. Now let's discuss one very interesting historical case, the case of Phineas Gage. Now Phineas Gage in fact was a railroad worker who had an explosive accident, and a metal iron rod, it penetrated his skull like this, as you can see the skull. So there was a penetrating injury. The iron rod passed through his skull. The rod was removed. Phineas Gage, he survived. But family members noticed that there is a change in his behavior. There was a change in his personality, and they used to say now he is no longer the Gage as he used to be. So remember, personality changes can occur if there is bilateral lesion in the frontal lobe. Now also let's discuss some important syndromes associated with frontal lobe, especially associated with the prefrontal cortex. Now depending on which area of the prefrontal cortex is affected, there are three syndromes which we can remember with the mnemonic DOME. So dorsolateral syndrome or bitofrontal syndrome and medial frontal syndrome. So coming to dorsolateral syndrome, also sometimes known as frontal convexity syndrome. Now dorsolateral prefrontal cortex is usually associated with cognitive function. So if this is affected, so there may be deficit in recall of previously learned information. There may be impairment in planning, especially, in fact, executive functions may get affected. There may be impaired attention, concentration, even depressive symptoms can occur. So remember, dorsolateral syndrome, especially there is impairment in cognitive functions. Then second is O for orbitofrontal syndrome. Again here, the orbitofrontal prefrontal cortex is getting affected, especially disinhibitory behavior, socially inappropriate behavior. For example, patient may make sexually inappropriate comments. That may be seen. Impulsivity may be seen. Poor judgment may occur. So a lot of such behaviors may occur in orbitofrontal syndrome. Now lastly, in the medial frontal syndrome, apathy may occur again because of involvement of the anterior cingulate cortex, poor motivation, decreased interest. So such symptoms may predominate in medial frontal syndrome. So these were some important frontal lobe syndromes which we have discussed. So this is the summary of this video. We have talked about delirium, very important neurocognitive disorder. We talked about diagnosis, etiology and management. Then we discussed a very important topic of dementia. In dementia, we talked about how to make a diagnosis, classification again very important, and we discussed some important types as well, such as Alzheimer's disease, Lewy body dementia again important, and some of the other causes. And again important topic, especially for your exam, is also management. Then we ended with discussing the last neurocognitive disorder, that is amnestic disorder, and also we discussed certain other conditions such as frontal lobe syndromes. Now let's discuss some MCQs related to the topics which we have covered in this video. So let's take up the first question. A 50-year-old male had a road traffic accident and he was admitted in the hospital. 2 days later, he developed irritability, aggressive behavior and confusion. He was saying that he is at his home and he also had sleep disturbances. Again, you can see a lot of information they provided. There is an accident and development of some symptoms. And very important to identify these symptoms, there is confusion. that he's saying that he is at his home although he's in the hospital. So what is this? He's not able to identify the place. There is disorientation to place. So the diagnosis, what is now the likely diagnosis? Alzheimer's disease, mania, delirium, amnestic disorder. Again, we know that there is impairment of consciousness. So the answer is, it is delirium. Let's discuss the next question. A patient is diagnosed with dementia, and which of the following causes may show rapid improvement in the symptom? Options are Alzheimer's disease, Lewy body dementia, subdural hematoma, multiple sclerosis. So they are trying to ask you which of the following has a reversible cause, because if you treat the cause, symptoms may be reversed. So remember, out of these options we know subdural hematoma, it is a reversible cause. So please try to see what is the point they are asking in the question. Next question, which of the following is not classified as a form of subcortical dementia? Options are Pick disease, Parkinson disease, Huntington's disease, Wilson's disease. Again, I always say remember the name. If you remember the name, you will be solve such questions. Pick disease, we also know, is known as frontotemporal dementia. So here frontal and temporal lobes are affected. It's a cortical dementia. So the answer is A. Next question, a patient presents with fluctuating cognition, seeing someone in the room not seen by others. He also has rigidity and bradykinesia. His brain has Lewy bodies, likely diagnosis. So let's try to see what are the symptoms. Fluctuating cognition is the first symptom. Seeing someone when in the room not seen by others. So this is telling us that there is visual hallucination. Rigidity, bradykinesia, this is telling us that there are motor symptoms. Also the brain is showing Lewy body. So what is this telling us? This is telling us maybe the patient has Lewy body disease. But let's see the options. Alzheimer's disease, Parkinson disease, vascular dementia, Pick's disease. So something which we have in our mind as a first option, it is not there in the option. Then we have to see which is a close differential diagnosis of Lewy body disease. Remember, yes, it is Parkinson disease. So again, all these features may also occur even in Parkinson disease dementia. Next question, which of the following is not true regarding the management of Alzheimer's disease? You have to see the false statement. Aducanumab, lecanemab, donanemab are monoclonal antibodies used in the management. It is a correct statement. Donepezil is a cholinesterase inhibitor. It is also correct. Memantine is used alone and not in combination with donepezil. This is an incorrect statement. Rivastigmine patch may be used in patients who develop severe GI side effects with oral drug. That is correct. So the right answer here is option number C. Now let's discuss the next question. A 70-year-old female presents with memory impairment, difficulty in navigating in her house, language difficulties for the past 2 years. She gets severely agitated at times. She realizes her deficits. Now let's first look at the symptoms. So we know memory impairment, difficulty in navigating. Again, there are cognitive impairment, language deficit. So there is also aphasia, and 2 years is telling us that maybe it has a chronic course. She gets agitated when she realizes her deficit. What is this? Severe reaction, severe agitation. That's a catastrophic reaction. Now her MRI brain shows atrophy, especially in the temporal and parietal lobes. Again, all this is suggesting us that the diagnosis is most likely Alzheimer's disease. Now we have to tell not true statement of her condition. Now APP, PS1, PS2 are associated with early onset. This we know is correct. Neurofibrillary tangles, amyloid plaques are seen. This also we know is correct. Oxidative stress is a protective factor. No, we discussed with the mnemonic AD votes. Oxidative stress is a risk factor. Higher education is a protective factor. Yes. So the right answer is option number C. So this was about this topic of neurocognitive disorder. Now parting words from my side. Again, I always say, don't regret about the past. Let's learn from it. Many times we carry the baggage of the past. Sir, we have not revised during our prof years. We have not studied well. So we carry that baggage. Again, I would suggest don't, have those regrets. The best thing to get overcome, from those regrets is to learn from them. So let's, learn from our past mistakes, and also don't worry, don't overthink about the future. Let's have some hope. Let's have good hope for the future, that future will be good. Now, the most important point which I always say is focus on the present, focus on today, focus on the current moment. Maybe that is why we called, the current day as present. It is a present, it is a gift for all of us. So let's focus on what is there in our hand, that is the present, and let's give our best. So this was from my side, neurocognitive disorder. See you all in the next video. Thank you very much. May God bless you all. And as I always say, keep smiling, keep moving forward.